at basic indicators like child survival, maternal mortality, important indicators like that, and you put quite a few of them together, the countries in our region that came out as comparable or with better indicators were number 1, Rwanda, and number 2, Malawi. And then when you look at their expenditure, both of them per capita expenditure is about half of ours. I think Rwanda is about $50, Malawi is about 40. So you begin to see the same things, that it is not necessarily how much you spend. The qualitative outcomes of health care and the input-output of health care is not that obvious. There is a black box of what the relationship between inputs and outputs is. So that, for example, those of you who have followed the conversation in the United States about healthcare reform, Obamacare, and all of that, you will know that the US has very, very expensive healthcare system. One of the most expensive healthcare in the world in terms of cost per capita, the cost of health insurance and that kind of thing, and the expenses. It's very, very expensive. But it is, and for that reason, it provides some outstanding, some of the world-class care, but it leaves very many people behind. I know that because I have paid hospital bills for people in the US who didn't have health insurance, relatives, friends who didn't have health insurance and ran into some, including my own sister who had an accident and didn't have health insurance and had to pay health bills in America from here. So that she could actually take time off work and get sort of care. Because if you don't, either you work, or if you don't work, you can't afford care. And there's a bit of a problem. So you get to see how dysfunctional even a system of a very wealthy country can actually be. It is also it can be extremely divisive. It can be extremely divisive. Those of you who followed the healthcare US, the conversation around Obamacare was extremely divisive. Why was it so divisive? It's because you have got so many vested interests. You've got big pharma, pharmaceutical companies, because this is an important and necessary thing. It is easy to make huge profits if you have life-saving drugs, and you are not particularly ethical. You can charge huge amounts for it, and people will have to pay. And you have very spectacular cases of that nature in many countries. It has doctors and healthcare professionals who look at one way of doing things. You have politicians, you have community, you have communities of faith who have different worldviews about, like, Roe versus Wade, which is quite topical at the moment. So it's an extremely emotive and can be an extremely divisive issue. So what and in this country also we have had our conversations around the health workers and the county government and industrial relations issues, and between private and public, and between curative and preventive, and all sorts of things, and various people. Everybody feels very, very strongly because healthcare, their health is very, very important. So, building a healthcare system, a good healthcare system, requires a level of coming together that is probably more unusual than many other things. Hence the statement, why I found the statement by the Singaporean foreign minister about combining the three things: healthcare, social capital, and governance. I think because you have to have a lot of social capital so that people can do the give and take that is required for you to arrive at a solution. For the last year and a half or so, we have been involved in having that kind of conversation internally, doing a lot of thinking, going back and forth, consulting various people. And we think that we have framed an outline of a vision of a healthcare system that can work for us and can deal with some of the challenges we are facing, and both in terms of access, in terms of cost, and in terms of the risk that healthcare burden imposes on society. I want to highlight just one issue that I would like us to focus, to use that the issue that will focus our minds. As I was looking at the statistics and the performance statistics, I came across this particular indicator. You can find it if you go to the health indicators from the World. I think it's but I found it in the World Bank development indicators that 36% of Kenyan households, 1 out of 3 households, is at the risk of being impoverished by a catastrophic illness costs. 1 out of 3 Kenyans. So by being impoverished, note, means they are not currently poor. There are people sitting in this room. Okay, so we are not talking about people who are already poor. We're talking about people who are impoverished. And I want to give that particular issue a real life experience, because this is an SMS sent to me by someone I knew, and we haven't met for many years, about her situation and looking for assistance. And she said, "Hello, David. I'm reading this SMS. I've been battling breast cancer since last year, January 8. 8 chemos, then a mastectomy on the right side, and I'm now doing radiotherapy. 14 done, 11 to go. But I really thank God for his goodness. Been a long, tedious journey, draining in every aspect, but I'm determined to win." And she puts that sort of emoji there. "I'm totally drained financially. 1.7 million gone and counting." And then she says, "Please, kindly, from your heart's kindness, sponsor me for 1 radio session for 4,400 shillings as I figure my life out, and keep me in your prayers. Regards." I still feel tears when I read this message, because I read it often. I want us to think about this, because this is a thing that will happen to many of us, to many of our families. Not perhaps a self-thank pray, but we know for a fact that someone close to us, someone we care about, will be in this situation. How can we solve this? What can we do about it? And that's why I said this conversation. That's why I said this conversation will transform Kenya. Because if we focus and are able to come out with a way forward for the country on this issue, whatever we do will transform Kenya. Whenever we do it, it will be the one thing that, and I believe Kenya, we have a track record of doing things and setting the pace. And we have set the pace in development in many things. And I believe, I feel the conviction that this is our moment to set pace on one of the most important things that distinguishes human achievement. Thank you very much for listening to me.
Thank you very much, David. Leaders present and professionals, doctors, and people in the healthcare space. Good morning. I think I join David in saying this conversation we are having here this morning is probably the most emotional conversation we are going to have. And let me thank Professor for welcoming us to Catholic University. I also want to thank you for the appointment. I will supply my curriculum vitae and my certificates because I think I qualify. As David has said, I have been around Kenya with my team, and there isn't a single meeting I have gone where there is, or in every single meeting I attended, including yesterday in Kilifi, you will find somebody with a picture of a loved one in some medical condition, and they are seeking for help. So, this conversation we are having here, ladies and gentlemen, we are not having a conversation about politics. We are having a conversation about life. We are having a conversation about our loved ones, people we cherish and people we love. And therefore, when we decided that we are going to have a different format of engaging in the politics that go into the 2022 election, and we figured out that rather than sit in some boardroom and draft a manifesto, we better go to every county and listen to the issues that are important to the people of Kenya. And let me give you a personal experience. Last week, we had a persons living with disability forum, and they thoroughly educated us and changed my personal view. I thought I always knew. In fact, we had put in our proposal that we are going to increase the number of special schools to take care of the children that live with disability. And to us, it looked very nice because we are providing additional facilities and additional schools. But they told us, no, we do not want more special schools. we want people living with disability to be integrated with other kids in schools. And that was fundamental. And they told us the more we have segregated schools for people living with disability, the more they are stigmatized. And that completely changed our plan. And therefore, it validated our approach that while we can sit somewhere and figure out what we think is not right, there is a wealth of experience, knowledge, and ideas out there that if we gave ourselves time and provided a platform, we could actually tap into that wealth of knowledge and better inform what we want to do. That is precisely part of the reason why we are having this conversation about health. Ladies and gentlemen, the reason why we have listened to many health issues in many fora, in fact, in every fora that we have attended at the counties, matters health have always taken a prime place. Community health volunteers, lack of drugs in our dispensaries, no personnel in our dispensaries, challenges of procuring drugs, and it's been consistent. And that is why we decided that we're going to have one forum where we will discuss only health. I want to say the following as I sit down to listen to stakeholders in the health space. If there is a sector that suffers trickle down and needs a bottom up, is the health sector. Today, almost 60% of patients, instead of going to a dispensary or a health center or a level 3 or 4 hospital, they actually choose to go to referrals. Because their experience is that there is no health professional at the dispensary. And if there is one by chance, there are no drugs. So if we must figure out how we are going to start at the bottom, how the health center, how the dispensary, how the community health worker is going to be empowered sufficiently to be able to deal with the challenge right at the root. If the dispensary is working, if the health center is working, it's the only way the level 4 and level 5 will work. As it is, the health center is not working because there are no drugs. The dispensary is not working because there are no personnel. And the level 4 and level 5 are not working because there is congestion. Everybody is crowded there. So, if there is one thing we must figure out from where I sit, you will tell us better. If there is one thing we must sort out, is we must take health to the bottom of the pyramid. If there is one other thing we must sort out, and again we are going to listen to you so that you tell us, we must sort out the health commodity supply chain. I don't know about the wisdom of having a monopoly called KEMSA. Some people must persuade us there is logic, there is reason why we have a facility that don't have drugs that are required at the right time, but they have drugs that stay in the stores until they expire. We just simply must sort it out, right? And you go to any health facility, you go to any county, they will tell you they have very serious challenges with KEMSA. As chair of the IBEC, we even tried to say, let the counties appoint 2 directors to KEMSA. They did about 2 years ago, but we are still on the same spot. The structure of supply of drugs simply needs to be redone. And finally, from where I sit, these are the 3 issues I wanted to say, is that we cannot continue to write on pieces of paper everywhere, and then the next day that piece of paper has disappeared. You come back to hospital, they write on another exercise book, and then it disappears. So health records become the biggest challenge and nightmare we ever have. I am aware that we wanted to procure a health records system, digital system, that would not only give us portability of patient data, but it would also help us in the whole space of telemedicine. But because of conflict of interest and other things, for 5 years, we have never managed to procure a health system. And therefore, if there is one urgent thing that must go into our 100-day delivery, is to figure out how to have a health system that will not only capture all the health data, it will also make patient data portable from one place to another without a lot of effort, and it will also make it that much more easy to sort out commodity supply and also help us with telemedicine. So, good people, this is the conversation. This is what I think. You are better informed about this sector. I know we have people from different sectors of our health space with a lot of knowledge, with a wealth of experience. And this is the forum for us to have that conversation, because, as you've heard, 30% of our population are one sickness away from poverty. And I think that's too much of a risk. We must do whatever it takes to sort out our health issues so that we can confidently speak to the words that a healthy nation is a wealthy nation. It's the only way we can take our economy to the next level. So, ladies and gentlemen, welcome to this conversation. I just thought I should, without necessarily directing what you have to say, but to also give you my personal experience from where I sit, and my personal experience as we went round with my colleagues here to various parts of the country. Karibuni sana. This is a very important conversation, and I agree with David that everybody should go away with a photograph to remind you that you were at the place where finally we sorted out the health challenges of our country. Asanteni sana.
Kindly let's give our chief guest a better clap. Thank you very much. We now move to the next session, where we are going to invite different leaders in the various sectors. And I will start with Mr. Simon of the Kenya Medical Association. We will not have any specific order or priority because all of us, we want the best for this country, and therefore we are all equal in trying to share our thoughts in the health sector. And therefore I'll invite Mr. Simon Kingondu, after which we'll have Dr. Timothy Olwen of the Kenya Association of Private Hospitals, and then we'll have the third person, who is Mr. Tony Kirwa, who will represent the referral hospitals. Thank you. I'll kindly guide us. For those of us who are closer to the back door, the washrooms are ground floor, so you'll just get out, go to the ground floor. There are stairs on both sides. And those of us who are seated in the front row, we have our station next to me. For the gents, we have on this side, and for the ladies, we have it on this other side. And the rest of us, we can use, we get out on the stairs on both left and right, downstairs. Karibu sana daktari.
Honorable Deputy President, all protocols observed, and my fellow health workers. I want to thank the team for inviting us to this forum. We will be presenting this to all stakeholders because everyone is a stakeholder in health. My name is Dr. Simon Kigondu, and I'm the recently elected president of the Kenya Medical Association. On this presidential side, we are waiting to see the outcome so that I can welcome fellow presidents soon. So I don't know who will be the president. So I am waiting for all of you there. I'll be very short. I am very passionate about what is called human resources for health. Human resources for health is all medical professionals. And just to use the so-called bottom-up approach that this team has decided to take. When I was the medical superintendent at Isiolo District Hospital, hospitals were run by the hospital and health management teams. And the team consists of the whole team, which, with the doctor at the head, consists of all other health workers. We have the chief clinical officer, the chief nurse, and everyone. And everyone met in a meeting like this to make decisions for the health sector. The so-called devolution of health actually centralized healthcare. They removed the power from the health workers at the institutions and centralized it to the governors. That is not devolution of health. What we had before, where the health workers were leading the health sector, was devolution of health. I will finish with another important statement. They devolved the wrong thing. They devolved the health workers. You will hear that all of us asking for what is called a health service commission. A health service commission is devolution. And just to illustrate this so that I don't take too much time, I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for 30 years. I have been in the health sector for a worker of Kenya. When I finished from the University of Nairobi, I was posted by the then Health Service Commission, which was the Public Service Commission, to Machakos District Hospital. I worked for 3 years. The government was good enough to bond me, but educate me to become an obstetrician and gynecologist. So I was paid for by the government of Kenya and came back to school for another 4 years. But they bonded me. When I finished, I was sent back to Isiolo District Hospital to be the first gynecologist there. For 5 years, I ran that hospital with my team. I had a wonderful team, pharmacists, clinical officers. The hospital was the center of the health system. The community health workers used to report to us. We give us guidance. We ran all the dispensaries together with the director, DMOH, and that was devolution. In this day and age, it would not have been possible for me to be posted to Isiolo. After Isiolo, I was posted back just before devolution, and luckily before, because currently where I am at Murang'a County Government, I cannot move because people have decided there is no Health Service Commission. Health workers are a property of the state. They are not a property of county governments. And when they can move between here, Kericho, Kisumu, that is devolution. Let us not be fixed on these, health workers are against devolution. The fact that I have worked in Cumberland, Nairobi, Isiolo, now I'm fixed in Murang'a because of what they call devolution is not devolution. So, Deputy President, the Health Service Commission is all we are asking for. Thank you very much. Yes.
I've actually discussions about the Health Service Commission. And you look familiar, probably we have met in one. Yes. Tell me, if we have the Health Service Commission and we have health services devolved in a manner it's understood in the Constitution, that counties are responsible, they employ, they promote, they can fire. How do you propose we go about the issue of you being on a payroll of the Murang'a County government, but being available to be deployed elsewhere to another county facility or to another national facility? This movement, how do you want us to balance between the counties as your employers currently and the national resource that you talk about, which I believe in, by the way? I believe there are certain regions in this country that do not have sufficiently trained medical personnel. And unless we have affirmative action at the national level, they'll continue suffering. So do you have any draft documents on the establishment of the National Health Commission and how it can coexist and blend with devolution?
Yeah, actually, thank you very much for that. That I am what is it called? Property of the county government in terms of healthcare is what needs to stop. When you have a Health Service Commission, you are an employee of the Health Service Commission, not the county government. But that does not mean the county government cannot employ. The Nairobi City Council had employees. If you find an area where the Health Service Commission cannot fit the person, then the county government can actually employ. The current scenario we are having is a situation that is not tenable in health. Which counties of the 47 have trained a neurosurgeon? None. None. Does that mean that the people at the counties do not need neurosurgeons? No. Previously, you are sponsored by the government, neurosurgeon, they look, Rift Valley, this particular area does not have a neurosurgeon. Post them there. He goes, capacity builds, and he can even now go to someone else. So that is not a quagmire. The devolution of health as it was, county government was supposed to deal with primary health care. It was correctly devolved by the legal paper of 2013 February by His Excellency Mwai Kibaki. But the politics of the people devolved health workers in a rush and illegally. We have written a lot about this, but that is not the point. The point is this. From a long time ago, for instance, when nurses were trained, their first 3 years were in Wajir, Garissa, Mandera. Why? Because it was difficult for Wajir, Mandera, Garissa to produce health workers. But the service is needed there. So the government trains you, you go work there for 3 to 5 years in your formative years so that you develop empathy that health workers need. All the nurses in their 60s currently are very empathetic nurses. They have served in far-to-reach areas, and that develops the human being. Then after that, you can go back to your home area or whatever, and it works very well. What we are having now currently, we're having public service boards employing people on the merits of their tribe or who have paid. That is not a sustainable system for this country. We are having medical interns who are in their 8th month without posting. They haven't been posted. How can you have your knowledge in medicine would have gone, and yet the state has used. David D can calculate how much you have used to train that particular, because there's no health service commission. When I finished, I was posted immediately to Machakos. When I finished, I became a medical officer, and then after that I was trained as a gynecologist. That's a resource. This country should not be practicing poor medicine for poor people. They should be training the people. You should be having continuous specialization. And this can only be done within the context of a health service commission and an organized health system with health workers at the leadership, not the politicians. COVID came. Initially, politicians tried to run the COVID program. It was a disaster. When they engaged the health workers, and specifically the Kenya Medical Association and Kenya Clinical, I can see my colleague here, Kenya Clinical, and the nurses, COVID was managed well. But professionals cannot be removed, then you expect a health system to function. So, a health service commission is not anti-devolution. It actually helps devolution. If I wanted to go and serve in deputy president's place, today I can't. I'm locked in by a county government. Moranga will refuse and say, no, this is our person. We're having people not being released to go for postgraduate training. We are not having specialization of the other cadres because we do not have a coordinated way of managing health, which was there before. And one more thing that I forgot is that we need to set aside funds for research and granting. If you do a research on the health system, then you will move away from political statements like devolution of health is good, with facts. The facts are on the table. A health workforce that is mobile and can serve in various places and linked to the various referral centers is what you require. And that can only be done by a health service commission. And we have a bill for that. We actually gave that bill from 2012. We wrote the health service. Not even that. The Health Service Commission was in the Constitution 2010 and it was removed in Naivasha when the ministries came in and they refused to operationalize it. So health is wealth. We do not have health of this political party or health of this individual of this political. Health affects everyone. Yeah?
Just one question.
Yes.
Listening to you. Steve. And I can see the passion you have in what you're saying. But let me ask the following. As I have worked with many governors in my capacity as chairman of IBEC, that brings together the county governments and the national government on matters to do with budget and economic issues. Now, I listened to the governor, for example, of Mandera, and his biggest argument for success in devolution of health is that they never had a doctor for a long time. Now, he has hired a record number of staff. I can't give you the figures. And that for the first time, they even had a cesarean section performed for the first time in Mandera because health was devolved, right? And their argument of the other side is we must not make health a privilege for those who can afford. We must make health available for everybody, irrespective of where they are. And the only way to keep a health worker in Wajir, for example, is if you have hired that health worker in Wajir itself. Otherwise, within a very short time, they will migrate. And they have data, you know, to support that people make technical appearances in the areas where there are challenges, and everybody wants to come to Nairobi and the big towns and do their thing there. So, you know, to an ordinary person in El-Wak who now has a nurse or a clinical officer in El-Wak who has never been there, yeah, until the counties came. How do you persuade them that devolving health has actually centralized it rather than devolved it? You know, I'm talking about a practical situation.
Can I add?
Okay. Just hold on.
Let me add. Thank you very much. I am so glad that we are having this conversation the way we are having it, and that it is an emotive conversation. And those are the things which need to come out. So I want also to speak from the other side, as you have, but really to add actual data to what you have said. I have data here which I used, I was working with when we were doing the Constitution. And luckily I found that I still have it. It compares the distribution of health infrastructure between Kiambu and Tana River in the year 2007. Kiambu then had a population of 800,000 people, and Tana River had a population of 220,000 people or so about. In terms of facilities, Kiambu had, they were matched. In fact, Tana River had more facilities per capita than Kiambu because CDF had already been building facilities. So Kiambu had 2 public hospitals, 11 health centers, 523 health beds, and 14 dispensaries. Tana River had 2 hospitals, 4 dispensaries, 221 health beds, and 29 dispensaries. So Tana River had more dispensaries because of CDF. When it comes to health workers, Kiambu had 6 consultants, Tana River 0. 15 MDs, GPs, Tana River 0. 1 dentist, Tana River 0. 1 pharmacist, Tana River 0. 22 clinical officers, Tana River 4, 84 registered nurses, Tana River 5, 336 community nurses, Tana River 38, Kiambu had 31 lab technicians and Tana River 2. This was Kiambu district, which is smaller than Kiambu County now. When I did some research and tried to establish the reason why, is because in a centralized system, doctors preferred the places which were closer, of course, to Nairobi. And Kiambu was the most preferred because it had the most opportunities for working in private hospitals in Nairobi and elsewhere after hours or even during working hours, what doctors call locums. Yeah? So that's the other side. The fact that a centralized system, particularly where you have lack of transparency and, let's say, to be honest, corruption, the business of posting health workers in Africa House was very lucrative, so that health workers can be posted to the places which are more favorable to them. These were the conversations we had during the bombers chats around the Constitution. One of the most striking things I remember after devolution was seeing a tender by the county government of Garissa or Wajir very early on, and they had advertised for 30 maternity facilities, what you call like maternity hospital type things, facilities. And I said, these people, how can they build 30 maternity facilities in one fell swoop? But when I read the document in a little more detail, I realized that each of them was 6 beds. So what the county government was doing was taking the services closer to the people, while in a centralized system, it is more likely that one big facility would have been built, because that's the kind of facility that brings the sort of sophistication that health professionals want. So we have this tension between downward accountability and the sense that health professionals feel that they should be one body. And to point out, having a system with a health service commission, even if it goes all the way down, or something which is accountable to the top, we call that decentralization, not devolution. Because that is a decentralized structure, but it is parallel. Secondly, the idea that you have the state, there's a sense of conflating, a hearing of conflating the state with the national government. The state includes county government, and in fact our constitution is very clear that they are 2 distinct entities but are complementary and they should work together. That's a long sort of framing of the question. I do believe, how do we square the circle between, I think, what health professionals see as works for them in terms of service, professional development, and doing their work in the way that they think they should have some professional autonomy, and the downward accountability and dealing with the governance issues of the fact that in our own self-interest, we would like to work in the places which are most convenient, which are most lucrative, and where we are not as subject to sanctions for non-performance or for other things as we might be. And I believe there is merit in both sides. How do we then square that up? I believe, and I think as a matter of principle for us, that it should be possible for having a system which meets the professional development and that kind of thing, and of health workers, but is also accountable where they work. So that perhaps, I don't know whether the health service, we can have a health service which employs, so that you're in the employment in the public service, but you have an internal market that you then have to be given a contract by a county. And if the county terminates your contract, you go back and you are, there are some organizations, the UN works like that these days. You are employed by the UN, but you have to get a job. But if you stay for so long and nobody wants you, then you have to leave. Because to be honest, we cannot turn the clock back. The process of amending the Constitution so that it can look what the health workers want to do, let me finish, cannot happen. The task in front of us is to figure out a system that makes doctors accountable where they work, and that they can be sanctioned for non-performance. Let us not pretend that doctors are angels. And let us not have any people stand on moral pedestals or professional pedestals and say we are the only ones who know how this should work. Let us be modest. As I said, we do need a healthcare system, but we also need governance. And I think what I want to hear from doctors is how do we deal with the governance and accountability and performance challenges of having a system which people are not accountable where they work, and they are accountable to something they control. That's not the normal way that employment works.
Okay. And thank you very much for this question. And for so long, this has been the issue. The doctors, actually health workers, you must have a health system, and COVID brought out that well, that is centered around the health worker. For so long, we have been sacrificial lambs. You can as well die, but the politician has said, oh, I have a doctor there. We must move out of this number thing. The governor of Mandera claims this number of doctors, and county governments have done a fantastic job in health, in employing people and all. But the cycle, look at my cycle. If I was in devolution now, I would never have become a gynecologist. Think about it. I would never. I served the people of Machakos for 3 years. Then they said, we can now proceed you in your professional development, train you, but still work for us because we have paid for you your fees for a short time. And then after that, whatever you do, wherever you become a consultant, wherever, you can still continue being a public servant if you want. Yeah? But you have served your time. But you have looked at the bigger picture. In future, we will need a gynecologist. In Isiolo, which did not have a gynecologist. So, and that was before devolution. So even me, I can come and say, Isiolo had no gynecologist. Before devolution, by the time I left Isiolo District Hospital, it was an internship center, 4 consultants, 10 doctors. Also say that if I am to run the same, but the system as it is now, even as the counties claim to employ people, does not allow professional development and specialization and betterment of health of this country. It can't. Now that the governor is gone, and I'll give you a good example. Kenyatta National Hospital is employing medical officers with contracts which say that you cannot go to school. Professional development of medicine in whatever area you are, you must have continuous development. You cannot stagnate there forever. And I'll tell you the problem we are having now. I'll use a simple, the basic doctor. The basic doctors have been employed. They work for their 3-4 years. Then when they want to go to school for specialization, they are told, by the way, that position that we have, we do not have someone to replace you. So they are stuck. You cannot employ someone because county government is saying there is a payroll. If you had a health service commission, this doctor, medical officer, is released to the health service commission. The health service commission provides a health worker for that position. This guy continues for training. The service continues to the people. Yeah? And when he finishes, we now look, Mandera kuna neurosurgery, went, and you post him there. Mandera will never sponsor a neurosurgery. It's too expensive for them. Yeah. So I think with that, yeah.
Thank you very much, Simon. Again, I appreciate your passion in what you're saying. And that's why this conversation is very important, so that we can listen carefully and avoid making political statements that are convenient when we actually have a challenge that we haven't addressed.
Yes.
It is very clear that there is an issue, and we need to figure out how that issue can be dealt with going forward. Listening to you, Simon, I'm just wondering, it is true, and by the way, what you have said is correct, because it came to IBEC, and many counties were saying, we have doctors who want to go at the county's expense to go and continue their education. So we have to do two things. We have to pay for this doctor to go learn, and then we have to hire another person to do what he was doing. So the counties were asking, this is too much. We cannot have it. We cannot carry, you know. So I agree with you that there is a challenge. Counties saying they do not have the resources to do that, to give you a bursary or a grant, a scholarship to go learn, and then hire somebody else. Is it possible for us to figure out how we can continue career progression, we can continue to train more personnel, more doctors, more neurosurgeons, and all the other health professionals in the context of devolution, or we must completely get out of it? I think we need to find a middle ground, a balance between those two. If we do, we will not only satisfy our health workers, but also keep devolution doing what they are doing. And Daktari, I am sure you agree that devolution has done some things right. Yes. You agree with that?
Totally.
Yeah? So we just need to correct what they have not been able to do. And I agree with you 100%. That issue came to IBEC, where counties were saying, we don't have the money first to give a scholarship. And even if we did, it means we have to hire somebody else to do, because, you know, going to train for a postgrad is not going to take months. It's going to take minimum 3-4 years. So for those 4 years, somebody must deliver the service. So while I agree with you that a health commission who has a bigger deployment of doctors would easily replace that doctor from somewhere else, but we need to contextualize it around what we actually have now in our counties. And I think there is a possibility of having a conversation that will give us that balance.
And Dr. David said something that I really need to correct. There is no problem with a doctor working in Nairobi, wanting to work in Nairobi. Why? The terms and conditions, availability of social things are there. So it is upon the government to ensure that out there, you create an environment that allows me to have my children with high quality schools and things like that. Therefore, it's not a problem for people to move to a place where they want a betterment of their family. And on that note, currently as we speak, medical health care workers working for national government have better terms than we in the counties. My people of my age. I've worked in
Contemporaries.
my contemporaries. I have better terms of service at national and Nairobi than in county. Then why should you then expect me to be the sacrificial lamb? I'll give you one example. When they devolved, mortgage was not devolved. Mortgage was left for the national government employees. There is no county which has mortgage facility, despite them being taught by national government before devolution how to. We don't have. Then you expect your colleague has a house, you are there working in the county, your pay is less, your benefits are less, you have less access to social amenities. So for government, DP, it is the role of government to equalize health workers. And when I worked in Asal, the day I was posted to Isiolo, my house allowance was reduced by 30,000. But we were posted with someone in another area whose allowance is that. Then people complain, why do people want to come? Because of these disparities which have not been addressed. So you're treating people differently just because they work in different countries, yet we are qualified the same. Yeah. So in terms of progression, I think it's very important for government to equalize what the health workers are getting.
Agreed, Simon. Relax. Agreed. Asante sana.
Your Excellency, the Deputy President, the Kenya Kwanza leadership, all distinguished guests who assembled here today, including our host, the Catholic University. I'd like to first express my appreciation and express my gratitude on behalf of Kenya Association of Private Hospitals for inviting us to this forum. My name is Dr. Timothy Olweng. I'm the Secretary General of Kenya Association of Private Hospitals. I'd like to share a few perspectives. I had a brief presentation which was shared, but apparently they have some challenges with projection. So I'll just speak off the cuff. Now, in terms of what we would request anybody who potentially is going to be in government is in terms of certain changes that would improve our healthcare system. For example, universal health coverage is one of the topical issues and one of the most important things. So there has to be measures put in place in terms of accelerating the achievement of universal health coverage. Now, just to elucidate a little bit, the term universal health coverage is not necessarily fully understood by everyone. Universal health coverage has got three important facets. First, in terms of providing equitable access. It's not just access, but equitable. In our country at the moment, we have got access in general, but it's not equitable in terms of, there's a lot of regional disparities in terms of accessing healthcare. Access to health services and the entire range of health services that are required, but also they have to be of sufficient quality to be effective. Because in the absence of them being of sufficient quality to be effective, at best we can talk about universal health care, but not coverage. Now, one of the things that happens whenever we try to push towards universal health coverage is one of the easiest things to increase is access. So for example, if overnight we got the resources and we said the entire population can be able to go to health facilities and get health care, health system capacity cannot increase overnight. And so what has happened, even in our case, in the time when we have had this push towards UHC, is that quality has dropped. Because health system capacity you cannot train health workers, for example, you cannot build facilities and have the diagnostic facilities and so on overnight. Then in addition to that, there's the issue of financial risk protection. And this is one thing that the earlier speaker, especially Dr. David Ndii, brought up. We cannot be exposing people to financial hardship on account of procuring health services. And the only way that that is going to change is if we change the system via which we finance healthcare. Now, healthcare financing, for example, to achieve UHC, you can have two approaches. You can have a tax-based approach, where the government primarily is a provider of healthcare through taxes, and then you can also have social insurance as a vehicle, which is the avenue we're trying to use in Kenya. Now, in the absence of us having a pooling system where we're going to pool resources, we will never get rid of the issue of people being impoverished as they seek healthcare. So the pooling mechanisms can be through, for example, tax-based systems or social insurance, as I said, but we have to eliminate the issue of paying for healthcare at the point of service. So we have to have a pre-financing mechanism, and pre-financing mechanisms only work when you pool resources, either through social health insurance or through private insurance. Out-of-pocket payments need to be eliminated. In fact, in our country at the moment, I think the data that they have from the medium-term report on the Kenya Health Sector Strategic Plan said that still we have got 8% of our households that are spending monthly more than 10% of the total health expenditures on healthcare. And that goes all the way to the point where we've got people who are being impoverished by procuring health services. The social health insurer, that is NHIF, there have been a lot of reforms that have been proposed of late, and it is in terms of trying to increase the pool or the base of people who are contributing to this fund. Now, insurance is about keeping your promise. And I don't think there's going to be any way, and I challenge anyone to, if you're going to put a mandatory system and say you're going to start arresting people who don't have NHIF insurance if they can afford to pay for it. It has to be that we deliver value and people see the benefit of belonging to this system. And NHIF has periodically has fallen short of this promise. And that is a challenge. Now, you have got the biggest challenge they have in terms of financing. You talk about mandatory contributions, yes. But the challenge is, and especially during the COVID period, we saw that there was a significant reduction in the voluntary contributions because people just didn't have the money or didn't see the value. So you've got people who contribute periodically when they perceive they're going to benefit. And that aspect of adverse selection is what even private insurance companies complain about. So people go and procure insurance when they anticipate a need. And after that has been taken care of, then they stop contributing. So one of the things that we have to do is look for a way in which we're going to have consistent contribution towards this scheme. And that's why the issue of the indigent people, I don't like that term very much. I think people who are, I'll say, economically disadvantaged should have contributions provided by government. So that's one of the ways in which we're going to increase the tax pool. But even as we talk about employers also contributing or matching their contributions that has been suggested, we have got to see an increased milieu of benefits. And that is what we have not seen in the current system. We have seen enhanced contributions, but we're not seeing the enhanced benefit packages being rolled out. Now, I've talked about out-of-pocket payments. Now, the other thing is the rising cost of healthcare. This is one of the items that we have got to handle and handle decisively. There has to be a systems approach in terms of dealing with this because it is not a simple fix. I come from the private health sector, and we have always been the bashing people, boys. When it comes to cost of healthcare, they say private hospitals are the ones who are charging too much. But the inputs, if you look at healthcare as a product, the inputs that produce that product, a lot of the time we don't determine the cost of those. And that's why there has to be a collaborative effort and a concerted effort to bring down these costs. For example, it is not a secret that since, for example, we had unionization of healthcare workers in this country, the costs of payroll and costs of employing health workers have gone up. And that is a fact. We've got other inputs. For example, pharmaceutical supplies are a significant component of the health bills we pay in this country. Why is it, for example, that when you go to a place like India, we pay for the same branded drugs that you'd buy here for 3,000 shillings, you can get it for 600-700 shillings. I had an experience like that as a doctor when I went to a hospital in India, and I started looking at the packaging, wondering whether it's a genuine product they had given me, and I could see the pharmacists getting irritated, because for me, I could not believe I was getting it at the price I was getting it. So in the absence of us having a manufacturing sector that is robust, in the absence of government somehow entering the fray and trying to be able to regulate the prices of these commodities, we are not going to control the costs of health. In addition to that, there are other drivers of healthcare costs. All commodities. For example, government has a role to play. We have got a lot of taxation right now on a lot of the inputs that are coming in for the health sector. We cannot say that we are trying to promote universal health coverage, and yet at the same time we are taxing the inputs that are going to bring down the costs of healthcare. I come from the private health sector, and we have seen in other sectors, for example, the government gives incentives. You've got people who get tax holidays when they come and invest. And the rest of us who are local investors are sitting and wondering, why would the foreign investors get preferential treatment over us? And if I was a foreign investor, before I come and invest in a market, I want to see how that government is treating its own people. because that becomes a reflection of how I'll be treated a short while down the road. So the cost of healthcare has got many facets, and that needs a concerted effort in terms of bringing down costs. One of the other major things is the mechanisms we have for healthcare provider compensation. For example, the traditional method, especially in the private health sector, has been fee for service. You walk into a facility, based on the inputs that are used in terms of providing care for you, a bill is generated, and that's how you pay for it. At the other end of the scale, the extreme end, we have got a system which we call capitation, where we decide that there are a certain number of people we want you to take care of their healthcare needs. We decide on a certain amount, we provide it to you, and in that way the risk has been transferred to you. So that's a capitation system. In the recent past, we've also got a fixed fee for service system, which especially private health insurers have been trying to introduce, and which the private sector feels is very unfair in the sense that they're transferring the risk of taking care of the clients to providers. And a lot of the time without notifying the clients that that is what they're doing. So you're told, we'll pay you for every outpatient visit 2,500 shillings. The person who is coming for care has not been told that's the arrangement, but what happens is the tendency is people try to reduce the costs of care per individual, and therefore quality of care goes down. And that is something I think we should not encourage in our system. The other thing which determines the healthcare and where government has got a major role to play is what we refer to as social health determinants. There are certain things, for example, socioeconomic factors that have been known to be associated with poor health outcomes. For example, the level of education has a bearing on people's health status. What kind of jobs they have, what kind of income they have, the kind of environments they live in, and other health behaviors, for example, smoking, their sexual habits, alcohol use, and so on. So you'll find the truth of the matter is the determinants of health that are within the control of the individual are actually a very small percentage, between 30 and 40%. The rest you're actually relying on other people. For example, as an individual, you cannot change the healthcare system in which you go to seek healthcare. And that's why, for example, we have a big challenge, which I would also like to mention at this point, the issue of cross-border contracting of health services. A while ago, I sat on a task force where you could see the intention was to try and restrict the number of Kenyans seeking treatment out of the country. And the tendency was try to block it and try and regulate and say you have to explain and get permission before you leave. And my opinion was, it is not workable. What we need to address is why are the people leaving this country? If it's an issue of cost, address the cost issue. If it's an issue of quality, that is a challenge to us as the healthcare providers, whether individual healthcare providers or institutional ones, we have to work together to improve that quality. If it's an issue of being able to get some of the expertise, let us work, as opposed to having people going out of the country. Can we have some of these other organizations or people from other countries come and work with us to increase our capacity so that we provide the care locally? So there are a lot of things that we have to work on in terms of intersectoral collaboration. When I talked about social health determinants, for example, infrastructure. There are a lot of people, especially in far-flung areas of this country, who can't be able to access a health facility because there is no road to be able to get to the facility. Or the security is not there for them to be able to go to hospital at night. Those become things that we need intersectoral collaboration, and that becomes the role of government. Agriculture, for example, food security and nutrition, that impacts on our health. And then there's the issue of violence and injuries, which has become a significant contributor to health morbidity and mortality. And I'm referring to violence and injuries. Again, there's a predilection for lower income areas. That is where there's a lot of it. But, for example, road traffic accidents, and especially in terms of the border sector, we have got a lot of health-related injuries that have occurred. So I think there is need for us to be able to regulate that sector to make it safer. Much as we appreciate that it's one that delivers a vital service, it needs to be regulated. I want to touch on the issue of poverty. There's a simple saying that poverty is not good for your health. In fact, poverty is bad for your health. And poverty is one of those things that is inextricably linked with poor health outcomes. Because there are so many deprivations that come from that. For example, it is a barrier to accessing healthcare because, for example, if you have to make out-of-pocket expenditure and you cannot be able to pay for it, you can't access the self-services you need. In addition to that, I've talked about violence, but poverty in itself Ill health itself is also a cause of poverty. So there's causality in both directions when it comes to this. So in terms of improving the socioeconomic status of our populations, it becomes important in terms of improving our health. Then there's the role of the state. And the state must play its part. I've talked about resource mobilization in terms of healthcare financing. So you have to get it from primary and secondary sources. But there's also the stewardship and regulation, because you can't have any sector operating without stewardship and regulation. So the state should provide that in terms of setting agendas, in terms of policy, in terms of legislation that is required, and also regulating or controlling the health insurer, social health insurer, which is a very important component of being able to deliver our healthcare needs in this country. In addition to that, there's the issue of facilitation and coordination. Conducive investment climate. I talked about that with respect to the private health sector, but in general, and I'll give an example. The health sector, for now, we have got a myriad of licensing regimes, licenses we have to get to be able to deliver service. At the beginning and at the inception, we knew that it is a medical board that has got the mandate to register health institutions. So we pay them fees. After that, you had got all these other smaller boards within that umbrella. The pharmacy and poison boards becomes autonomous. Now we've got the medical board who checks all these licenses at the same time, and we pay them fees. Then we have to pay the pharmacy and poisons board. Then we have to pay the radiation protection board. Then we have the Kenya Medical Laboratory and Technologies board. Now even the TV people come and count TVs in our facilities and want us to pay for the number of TVs in our facilities. We have a fee to pay. So you find by the time we are being able to run a medical institution, you have got, at a certain level, you might find that you're paying 500,000 shillings a year in fees. And interestingly, sometimes, again, the ones who pay the fees are the ones who are over-regulated. The people who are not licensed, we see them continuing to do business undeterred. Whereas there are times you can have somebody coming from the medical board, this was a practice in the past, and telling you that your license is not hung on the wall where it should be. He knows you have a license, but he's saying it's not hung on the wall as per the law. So I remember asking one once, so where do you want me to hang it? In my office, in the outpatient clinic, in the lab, or in theater? Where do you want me to hang it? It's immaterial, as long as you know I'm licensed and I've paid for it. And yet you have other people who are not licensed in the first place delivering health services next door, including the doctors who, in quotes, who advertise on the electricity poles and promise all manner of care. The government also has an issue, and this has come up in terms of human resources for health. It has also come up the issue of coordination between the two levels of government. Sometimes you've got over-planning, sometimes you have duplication of functions. And that issue of coordination also falls at the doorstep of national government. In terms of financing the healthcare services for those who are vulnerable, that also falls to the government. I think they already do it for the military, and we mentioned the indigents who also need to have their fees paid. We talked about the cost of healthcare and the human resources for health. I would not want to flog that horse any further. I think Dr. Kigondu did that topic sufficient justice. Now, the other thing which we need to talk about is healthcare disparities. And I mentioned this earlier, but these healthcare disparities are there in terms of human resource. They're there in terms of health facility density, in terms of you've got such huge disparities in terms of the regions, the number of facilities you have in different parts of the country. And then the other things to do with the proportion of healthcare resources that are financed out of pocket versus pre-financed also varies greatly from one region to another. And lastly, by law, the 2017 Act, there was an issue about there's a constitutional right to health. And that, if you ask me, there has to be an addressee of those rights. I don't think that responsibility falls upon the citizen or private investors. It is a responsibility of government to be able to deliver healthcare for its citizens. Now, when we had the issue of emergency response, and this is a challenge that has been going back and forth. You have got people who get accidents and they rush to health facilities. Who is supposed to meet those bills? There was a proposal in 2017, and in fact it was legislated that there was an emergency response fund which was supposed to be set up. It has never been operationalized. And that needs to be done so that you can also encourage, for example, private health facilities are run by private investors. You cannot have them incurring huge costs which are never compensated, consistently to be able to take care of. And that, you know, it's also against the law to be able to detain people for not paying bills. So there are a lot of facilities, especially those who are located along major highways, incur enormous cost in terms of being able to provide healthcare services to citizens. And I think that's the role of the Emergency Response Fund. So I'll keep it at that. If there are any questions, maybe you can, I can address them. Thank you.
Thank you very much, Dr. Olwen. I think you have put things in very good context and perspective. Let me just ask two clarifications. On the matter of commodities, especially on the matter of making it, you find that you gave the example yourself. A drug you're buying here for 3,000 shillings, same drug in the next country is a fifth, quarter of the price. You find that you can buy Panadol at 20 shillings in one facility. The same Panadol, you buy it at another facility, or you get it at another facility and you are charged 50 shillings. So, what is the remedy in your opinion, and who should do that? Is it, do we find a place? Is it a combination of Kenya Medical Association, medical practitioners, private people, and government to standardize that particular subject, so that, because a big contributor to the cost of health is that disparity in how much it costs, the commodities cost. That's one. Where would you what suggestions do you have on how we can fix that? That's number one. Number two, you have given two suggestions on mobilizing, and I think you have suggested that pooling is the most effective or efficient way of delivery, and pooling can either be through a tax system or a social health, as we are proposing. Do you have any suggestions on what Kenya Kwanza can do? Would you say the social health would be better than the tax system, or what suggestions do you have? And then finally, in terms of, and I hope I'm not loading too much into your plate, you also talked about a fixed cost approach. Can you elaborate there? I didn't quite follow it properly. You know, the two suggestions you made. I think what preference would you think we should go?
Okay, so firstly, with respect to the prices of the commodities, first of all, there are various dimensions. We have to understand, first of all, that we are comparing apples and apples, not apples and oranges. So in terms of, first of all, control in terms of quality, that role falls, for example, for pharmaceuticals with the Pharmacy and Poisons Board. We have got drugs that are branded drugs, we have got drugs that are generics. The key thing for healthcare providers, and I talk about as individual practitioners, we want to be sure that we're getting drugs that are of good quality. There are times the drugs have fallen short. And as a doctor, you want to be sure you're giving your patient the best. So first of all, in terms of ensuring that all drugs on our market, first of all, meet the quality threshold and they work. If that happens, then now we can prescribe the cheapest one. And that, of course, is one of the ways of exerting pressure on those guys who are overpricing their products to bring those prices down. In India, for example, they have got the volumes. And they told the big manufacturers, if you want to be able to access our market, you're going to sell it to our clients at this price. Kenya can be able to do the same because guess what? In this region, you have got drugs that are being sold, same drugs sold in Uganda and Tanzania at a lower price because the feeling is Kenya is doing better economically, we can charge a premium. And so sometimes they even stop people from getting products across borders by changing the name or changing the packaging. So that it says this was for the Tanzanian market and this for the Kenyan market. But it's the same drug. So that's why I'm saying government has to play some hardball here, because at the end of the day, we are not going to bring down costs of healthcare if this component that is 30 to 40% of the bills is not managed. So if we can be able to enhance our manufacturing sector, because we also have a manufacturing sector in Kenya that needs support, and especially for basic drugs that are not too complicated, and consumables and other products. If we can be able to boost that sector, and that's why I was talking about the incentives for the health sector. If we can be able to produce our own, then now we have got some that we can also be able to compare with others and make sure that people charge a price that makes sense. The other question, sorry, I've even forgotten the second question. It was relating to
whether we do tax or we do social.
in terms of being able to finance the financing, the pre-financing of. I think at the moment the truth is we're actually doing a mix of both.
Yeah.
If you were to ask me, you know, the danger sometimes with the essential services is governments don't want to divest totally from them, because sometimes the private sector can be able to arm twist, and you might have a certain segment of the population not being able to access services. So in our situation, I think at the end of the day, government health facilities must be there to a certain extent. Because again, the private health sector, you find in certain far-flung regions where it might not make economic sense, you'll not find people willing to invest in those areas. So, but at the end of the day, the social health insurer is the best option. The reason is, number one, it pulls a large number of people together. Already we have got a regime where it is mandatory, especially for those in formal employment. You don't have a choice. Whether you have an alternative insurance or not, you already don't have a choice. So there's already a significant pool of money which is coming in regardless. But in terms of the efficiencies of that social regulator, that has to be. There was a time when there was rumor that their management costs were going close to 50%. Of later here, now it's come down to the tune of 20-15%, which is more manageable. But in terms of being able to structure and reorganize those organizations and make sure that they're delivering on their objectives is important. There was even talk once of being able to segregate the duties of the payer and the people who are providing the benefit package in that sense. So those are proposals that are there, but in general, the social health insurance way, I think, is the easiest way to go. It's the easiest way to go, but it has to be within very good and strict controls. Now,
I think the framing is correct.
yes.
Do we do fee for service, or do we go the capitation route, or there is room for a mix?
There's actually room for a mix. Fee for service has got certain dangers. And this is the reason why even you find, for example, when the NHIF rolled out the certain schemes that they have, when you've got very large numbers of claims, as numbers go up, those administrative costs of vetting claims, managing them, and paying them becomes extremely high. So what happens is that's why people want to move towards a capitation model. Capitation has got dangers, though, because you can have healthcare providers doing what you call skimming. If you've got people whose health needs are going to be high, the tendency to avoid registering those people in your facility. Now, we can go towards a value-based system, and that's the merge somewhere in between. Where what, for example, we are saying is we are paying you for a product you're delivering. So it's a value-based system. The danger with the fee for service is that the tendency is the healthcare providers are an interested party. There's churning. The more service you provide, the more you get paid. So you see there's a tendency to waste resources. So, and you must remember there's also that agency relationship, there's a bit of a mismatch, because there's also, you must remember there's also the asymmetry of information. Health is a pretty specialized area, so you have got to take our word based on what we recommend and what we do. The question is, if I'm an interested party, am I providing you the best care, or am I providing the care that's in my best interest?
listening to you, Daktari, we are a value-based system. Did you say that? Which is midway between capitation. Capitation, the temptation will be you avoid people who you think they will take more from your service.
Yes.
The other one, you will give, even you will be too generous.
Yes.
Because you want to be paid.
Yes.
You know? So we must find an in-between.
Sometimes at the end of the day, and this is what sometimes at the moment you can say diagnosis related groups. For example, we say, instead of talking about this, we'll say for this particular service, we'll pay you X amount, and we agree on that charge. In fact, the truth of the matter is it forces people to be more efficient, because now it means that I'm going to provide that service as a fixed cost. So there's interest in me lowering those costs. So over time, you might find the costs of delivering service actually go down within a country. So there are very many mixes in between. I gave you the extreme ends. Capitation, the biggest problem we had, like with the NHIF system that was introduced for capitation, the rates were ridiculously low. Ridiculously low. Because you cannot talk about taking care of the health of somebody at 100 shillings a month. It doesn't matter how those numbers add up. For 1,200 bob a year, most people are losing money. And that's why you find a lot of healthcare providers are going to run away from it. Yet in the government, you can go to the government health sector, you will get the service, so to speak, but the commodities are lacking. So there's no point in going to be seen by a doctor and get your diagnosis done, so to speak, then there are no drugs. After that, you're told, go and buy the drugs from a pharmacy. So there's a lot of work to be done, and I believe, especially now that the conversation is happening, there's ways in which we can make our healthcare system more efficient so that we don't run in a situation like the US where you're spending so much per capita and you're not really getting value out of it.
Thank you very much. Because you're very resourceful, I want to get as much out of you as possible.
Okay.
Before you leave. I want you to just react to two things in terms of what you have said, and this is, you can see the direction we are thinking, and you probably have more conversation,
yes,
but so that they can be discussed later. One is procurement. On the question you raised about procurement, and the cost of commodities, and the choice of commodities, about the efficacy or the practicality of a stakeholder-owned or managed national procurement sort of platform. The idea here being, something we've been doing with petroleum, which is different from the subsidy that's gone wrong. But at some point, we got all the petroleum companies to come together, and they decide what quantities of oil they need, and then they pool their needs for that particular period, and they get one of them to put out a tender. And actually that brought the costs quite down, and then you pool, so it's a pool system.
yes,
And we're wondering whether that can work in the healthcare system, where both public and private, all the health providers, is a platform, and we say we need so much of this antibiotic, my need for this antibiotic is so much, my need for this suspension is so much, my need for this whatever is so much, and then you come up with a procurement plan and you decide who procures what so that you can bargain for better prices. That's one thing I want to, that's a direction we are thinking.
yes,
And that would be part of our way of solving the cancer problem. Because then when you bring in the private, yourselves in there, then your interest will be such that you will want to get the best products at the best price.
yes,
That's how we think we can discipline the public system, to be honest. That's one. The second one is between the capitation and the fee for service, about the option of a tariff system, where you have, for the social health insurance package, it has a tariff, where for every protocol that is provided, and it's agreed this is the cost-based, and you have a tariff for every protocol, and there is a system for you, for the system you setting the tariffs, so that as costs change, maybe they are adjusted quarterly or semi-annually or whatever. Would that sort of be a good halfway house between the pure fee for service, which is determined discretionally, or capitation?
Yes, okay. Thank you for those questions. Now,
Before you, can I add something before you answer? Or you want to answer that first?
Okay. Yes. So in terms of the bulk procurement, those are proposals that even as the private health sector we have had in the past. The challenge we have is we have, first of all, a very diverse group of organizations with different capacities. And I'll give you, for example, the so-called Big Five. They feel they've got a sufficient base that they can do their procurement on their own. So interestingly, they're actually the ones who procure at the lowest price and actually charge a premium, all right? And whereas sometimes those who are smaller cannot organize themselves sufficiently, and because of issues of cash flows and so on. So that is a very good proposal in terms of being able to bulk procure, because again, we cut off the middleman. And the bulk of in this supply chain here, the middleman is the one who is making most of the money. Facilities themselves, by the way, have got a fixed percentage that they're supposed to mark up their products. So at the end of the day, it's not going to necessarily change how much they make. The truth is the benefit will be passed over to the patient. So those are very good proposals. Originally, we have got other organizations that actually procure in bulk. The challenge is the supply is so erratic that they cannot supply as efficiently. You will put in an order and all the items are out of stock and so on. So for example, but those are very good proposals if we can get, and this way I'm saying the role of government can come in. In terms of the issue of pricing, the tariffs, even with NHIF, the current discussions that we have been having, which hit a stalemate, as you're aware, on many occasions, with, for example, the private health sector and the faith-based sector, we have got proposals that we have got certain tariffs that are supposed to charge fixed rates for certain, especially surgical packages. Dialysis was a big issue, for example. The only challenge that there was is they were pricing them below market to the point that we would not be able to deliver the service. And that is where now the stalemate comes in. NHIF should be able to provide care, first of all. They cannot discriminate against members. You cannot be told, for example, that if you've got another form of insurance, now we're not paying for you. You should pay to the extent that they're entitled. In fact, people should go to facilities based on the choice. There are certain facilities where you'll go and pay nothing. There are other facilities where you go and co-pay, but that is a choice the person makes. For their members, there have to be facilities where they go and provide all the service. The only challenge was when they were, for example, for dialysis, they were paying 9,500 shillings per session twice a week. Now they wanted to change it to 6,500 3 times a week. But the 6,500 is not enough to cover the cost for one session. So guess what? And they were saying you cannot charge anything other than the 6,500. What that was going to do is lock out all the people who are getting dialysis service and now actually have to pay for it cash. And they were saying, why are you giving us 3 sessions a week? Most of us are okay with the 2 sessions as long as we don't pay anything. But if you say we are paying 3,000 a week, 3,000 per session, it means now I'm going to my pocket 6,000 shillings every week. Already people who have got dialysis with chronic illness are already so cash strapped that you cannot again put that premium on them. So that's one of the challenges. When, for example, we were told that you need to pay, to do cesarean sections for 48,000 shillings and not charge anybody any in addition to that. The medical board alone says doctors are supposed to charge 60 to 100,000 shillings. So how are you telling us we're going to charge 48,000 shillings for the entire procedure inclusive of doctors' fees? So these are the discussions I'm saying that need to be rational. So let it be that if NHIF says we can only pay X amount, let them pay that and allow the people who are going to top up, especially going to private facilities or high-end facilities, do that. But for government facilities, NHIF should be able to cover the full bill for the patients.
So, Daktari, we have had hours on hours discussing this particular subject to negotiate on a middle ground between capitation and fee-for-service. And I think that's what David was basically saying, that we agree that if you're treating me for malaria, it's going to cost this much. If you're treating me for this it's going to cost this much. So that it now becomes your business to make sure that it's efficient, and because you'll be paid a standard amount of money. So I think there is need to now interrogate that further, and that's exactly what you're saying. Yes. That those are the negotiations that have been going on, but there's been a stalemate with NHIF. In your opinion, what are your thoughts around the reform of NHIF? We've had proposals of breaking it up into maybe 2 or 3. A regulator separately, an administrator, and somebody to collect the resources into do you think that is a conversation we should have? And do you think it may give us a chance to get to where we want to go? And where is the place of digitization or computerization, especially on matters to do with health records, the portability of health records, the whole space around there? What in your opinion, what's the way to the future? What are your thoughts?
Personally, I think NHIF, especially with the kind of reforms that have been proposed, NHIF is still, I think, a vehicle that can be worked with in terms of delivery of these health products. The only thing is NHIF needs to be responsive to the needs of its members, because people sometimes, NHIF sometimes they talk like they forget that they're a members fund. So you forget whose interest they're looking out for. It has to be they're responsive to the members' needs, and that's the only way the members will stick with them. Secondly, they have to make sure that we have got a symbiotic relationship with providers. NHIF doesn't own any facilities. So it cannot work to the detriment of the same facilities who are going to deliver on its promise to its members. So that engagement is one thing that is lacking. In terms of breaking it up, it might not necessarily be the case, because again, if you break it up, you might be breaking it up and reducing the pool that we have. The beauty of having a social health insurance system is that, first of all, it does not ask you about pre-existing conditions. You don't walk in and you say, oh, you've got hypertension, so we're going to cover anything except hypertension. So you've got somebody who is taking your premium, like sometimes happens with private insurers, and they're saying, we'll take care of you as long as you are not unwell. Then you wonder, so why am I paying the premium? It doesn't discriminate. That's the beauty of social health insurance. And then you've got the issue of being able to have those people who contribute, who are healthy, contribute to those who are unwell, those who are young, contribute to those who are old, and so on. So that's the social health principle. So NHIF is still a very good vehicle, but it has to be managed properly. Because NHIF is such a huge organization. I mean, how many organizations do you have where you collect billions of shillings guaranteed by the 9th of every month? And yet sometimes you find the structures you have within NHIF and the level of engagement, you wonder whether we're getting the quality of people who should be managing those kind of resources. And that's what we need to be able to do in terms of changing it and how you run it.
Finally, and sorry if I am taxing you, but finally, part of the challenge we have, as I said earlier, is commodities and the challenge with KEMSA, right? And before even I talk about KEMSA, that whole space around drugs, I spoke to one doctor, actually inadvertently yesterday, and he was telling me that they have a long list of drugs they want to register with us, with Kenya. They've registered everywhere else, but Kenya is a difficult nut to crack because there is a cartel of people who don't want anybody else to sell their wares or their drugs in Kenya. They've somehow found the way to lock it up just for drugs from certain suppliers. How serious is that challenge from where you sit? Do you think it is something we need to worry about? Or you think we have enough latitude to have the best drugs and the biggest variety?
You know, one of the reasons why I agreed to attend this session is if you're talking to the person who is going to be at the top. If that is corruption, there's no other way to describe it. let me tell you, all these systems we're talking about, all these organizations that have been set up, have actually got a very good foundation and very good policies. That's why they were set up in the first place. It is just an issue of how we are managing them, all these vested interests. When there's big money, all those other problems come in. So it has to be that we just committed in terms of, I don't think that there's need to replace those organizations. It's just to revamp them and let them go back to what they were set up for. The other thing which I did not answer, which you mentioned, and about the health records system, health management information system. 15 years ago when I was in the UK and I was looking for a health management information system for our facility, I went and I've got a friend who works at the NHS and he showed me how their system worked. And I looked and I said, why don't we have something like this? Because in Kenya, what happens, even from one hospital to another, you will go there, and I'm a medical professional, I'll tell you, they'll look at the MRI from this hospital, and he says, this is a radiologist I don't know, so I'd have to do an MRI again. This is the waste we're talking about. We have got a system where we are duplicating the services from Nakuru to Nairobi between one hospital and another. So every time we're duplicating tests, as opposed to going into the system and saying, what tests have you had done? And what's your previous diagnosis? We are diagnosing people sometimes every time they go to a facility, as opposed to having the information. So one thing we need to do, that is something we need. And at that time, my suggestion, I came back to NHIF. There was a system which was being sold, but it was way above what I could afford. I came to NHIF people and told them, you're the only ones who can afford this. And secondly, guess what? You're going to be able to now have visibility into all your providers, all your patients' conditions. So as long as the issue of patient confidentiality can be maintained, that's always the challenge. As long as that confidentiality can be maintained, there are benefits to that system, because even in an emergency, when you receive a patient, you don't have to be going through all the rigmaroles of being able to find out what pre-existing conditions did they have, what were they managed for, I've got a scar in the abdomen, what was the surgery for, and so on. That information will be available. But that is the waste that we're having in our healthcare system, purely because we've not invested in this one big system. So that's one of the greatest ideas that we can be able to implement.
Thank you very much, Dr.
Thank you.
Thank you for your insights.
Thank you very much.
Thank you very much.
Maisha tunaishi Kenya hii yetu jamani, ndio mke wangu, hatutatoboa hata kidogo na hii bei ya madawa. Aidha unauza shamba, utauza gari, sio mimi peke yangu. Kila Mkenya kuna hii shida na sijui itakujaisha lini. Hata naona ni heri kabisa niondoke dunia hii, niwache kufundisha watoto wangu, kuwapa taabu. Niende kabisa.
For us to be able to enrich this conversation, I'll invite Mr. George Gibore for a situational analysis before we proceed. And then other members, we kindly request you that we stick to the time allocated to us, because we have quite a number of presenters to talk to us. Karibu, George.
Excellency, the Deputy President, and the candidate for Kenya Kwanza Alliance, the Kenya Kwanza Alliance team, leaders here present, the health workers leadership present. My name is George Gibore. Good afternoon. I'll just want to take 3 minutes, as he has said, and highlight a few things. And I'm glad for the first speakers who have been here to have highlighted a number of issues that really are affecting the healthcare workers, the health system as a whole. Indeed, they have touched on a number of issues, as in accordance to the WHO, we have the 6 pillars that support the health system to function. One of it is the human resource, 2 is the health financing, 3 is the health infrastructure, 4 is the leadership and governance, 5 is health information and technology, and 6 is commodity. And as you'll hear, Your Excellency, a number of these issues have already been highlighted. I think I can start from the human resource, where probably we have been projected to have understaffing, which is a big issue. A big issue because it affects accessibility. Accessibility here to mean, I come from Migori County, where I was born and raised, but I work in Nairobi. But in Migori, Kuria, in Kuria, one of the sub-county there, my father at the age of 76 have never accessed a physician. And that is a fact. And probably the healthcare workers who are there also have some limitation in terms of training, which has been mentioned here. But of course, there are very few. When there are few, means that they are denied chance to go back and do further studies. I think that is what one of my colleagues was explaining here. And the WHO has given us a good platform on what we call the staffing norm, which we project that the country, for it to attain universal health coverage, must have at least a staffing of 23 healthcare workers to 10,000 population density. Now, currently, we only have 6 counties that has attained this, Nairobi being one of it, and Kiambu, and probably one of the last one is Nakuru. The last one that I remember is Nakuru. But the issue also, even for those that have met this standard, is that there is a gap in terms of the terms of engagement. So people who have the same qualification have been engaged in different terms, and they work like they come from a different country. This should also be addressed if you take up the leadership of this government, as you address the number of the healthcare workers. And our request is, at least you focus to revamp the human resource for health. At least when you come in, 20,000 healthcare workers at once can be able to propel us next to what the WHO want. In the health infrastructure, I need to say, Your Excellency, the WHO has given a recommendation that we meet the population density. So in any case, we do not need any brick and mortar. Now, our clarion call is to focus on what we call the primary healthcare approach. In the previous, Your Excellency, there have been a congestion at the higher facility, which means in terms of resources, the funding, close to 90% of our funding are done to the higher facility. That is the level 4 and above. So the level 3, level 2, and the 1 are left to vendor, or rather to actually work doubtedly without even the people who relies on them trusting them. There is no healthcare worker there. If there is, they are not enough. There is no facility, laboratory are not functioning because there is no laboratory technologist or officer or even the reagent to ensure that they are working when they are in the hospital. And even the pharmacy, when there is drugs, there are no people to dispense these drugs. So the people who dispense drugs do not meet the requisite training, meaning that they can sometimes not dispense drug by indicating that it is out of stock, only to realize that at the end of the day that these drugs expire without being utilized. So in the sense, it speaks back to where I started, and I call that if you come in place, the focus on the primary health care is intended to activate and empower this primary health care to ensure that they can function optimally and be trusted by Kenyan. When they are trusted by Kenyan, they will seek services there and they will avoid actually bypassing them, going to the higher level, which is a high-end facility. And in any case, a treatment for malaria at a referral hospital is costly than a lower level, where probably it will be 0 rated. But if you happen to bypass by lack of trust, then means a high cost. Now, if you do that, you'll prevent diseases. 2, you'll ensure that you are promoting life. 3, you'll do early intervention. And 4, you'll ensure that you do early detection, which now leads to early intervention, meaning that cancers can be diagnosed early and be able to take intervention at an early stage. So that is our clarion call. And the last one that I need to make is that indeed we have looked at the resources that we have been using. It is in data that all resources put together, this country in the last financial year, we utilized close to 550 billion. If this money is put into good use, every facility will have enough healthcare workers, and also we'll have enough commodities. We will have a working system, which all of us are calling here, on what we call the information technology, which the right speaker was explaining. And I want to emphasize only one thing about this system, because it can easily help us do make good progress in terms of managing the human resource, because you'll get to know where they are and where they are working. 2, it can also be able to tell us where we have the commodities, where they are not well utilized. If they are approaching probably expiry, you shift them to where they are needed without going to purchase others. And lastly, on that system, it will actually help us in terms of approving the claims that are made for purpose of pay, and it can actually only allow pay for services done for me. And if this one done, it will cure the issues of corruption alongside. And even for the drugs, KEMSA or whoever will be the supplier must own the drug until it is enrolled in that system, so that there is no drug that is lost in the system on the way it normally happens. And it will also empower to give us information on to know how to need to work on. That is to mean monitoring and evaluation, and get information that can inform the country where to move on. Thank you very much. I will want to end there because I don't want to belabor much for what our colleagues have already spoken about.
Thank you very much, my friend. It's okay.
Thank you.
Let's listen to your other colleagues.
Okay, thank you.
Thank you very much, George. I will now invite Mrs. Jane Karimi from the Kenya National Union of Nurses, who will also invite the Secretary General, the General Secretary, Kenya National Union of Nurses.
Your Excellency, the Deputy President of the Republic of Kenya, all protocols observed, and my colleagues in healthcare, good morning, good afternoon. Your Excellency, I stand here to talk about issues of health in a perspective of our bottom up, because we are talking to the Kenya Kwanza team. And Your Excellency, I want to take you through a very simple scenario, because what I wanted to speak about NHIF has already been spoken. So I just want to take you to where you started. And what you said, that you have been going around the country and you have met with several people who have issues on health. And I want to tell you that there is a mother who has given birth to a child and doesn't know the problem, goes to the next health center, takes about 6 months, loitering around level 1, level 2, and level 3 before she even reaches to level 4. By the time we are reaching level 4 hospital, we are doing almost a whole year. By the time we are reaching to level 5, we are going to our 2nd year. And when we reach to Kenyatta National Hospital, which is the highest level of our referral, we are doing our 3rd year. Maybe a child or even an adult. In Kenyatta National Hospital, let's take, for example, the person had a problem with the heart. The booking for the heart surgery now is, the bookings are up to 2027, or even some going to 2028. That is basically a bottom-up approach of an ordinary Kenyan in our country. And you can imagine the medical people, the nurses especially, who are dealing with these patients on a daily basis, coming to these hospitals, seeing them suffering, and going through a lot of torture. Basically, what am I saying? I want to put the task of improving our healthcare services in this country with the governance. And the people that I want to put into task, above all, is our parliamentarians. When we look at our NHIF, it is only in Parliament, Your Excellency, where we can make the right policies, the right laws, which can be able to work for our healthcare systems in this country. But what we see in Parliament many a times, it doesn't seem like those parliamentarians really have seen these patients suffering. And that is why, when a bill is brought in Parliament touching on health issues, it is not given the right timings, it delays, and the Speaker who has spoken here about NHIF has literally said that there are several amendments that are still lying in Parliament, and nobody seems to take the first lead to take these issues as a first priority in Parliament. So where is the catch, and where do we start? We start by ensuring that we mitigate the losses and the wastages that are in NHIF. Because when you see most of these patients struggling, it is because when they come to, let's use for example Kenyatta National Hospital, they are told that we need investigations. Those investigations are not covered by NHIF. So these people start another journey to go to look for money to pay for the investigations, and they can't even afford. They are living below poverty life. Even getting food for these children is very hard even for these people. So the parliamentarians should be able to enact laws that will be able to shape the NHIF. Majority of the Kenyans, they do not even understand what is a private hospital. And the Speaker who spoke here from private talked very well about financing of healthcare system. But Your Excellency, you can imagine how many people in this country depend on private institutions for healthcare. Very few. So the largest population is still untaken care of. So basically, Your Excellency, I would request you kindly, in the next Parliament, because we know that there are people who have not been able to go to Parliament through the normal process of going to get elected by the public. But we can nominate these people to Parliament. We know them. We can nominate them. And when we do the nominations, we will still nominate the politicians who have never seen a mother coming to the hospital with a child for a whole year, and that child ends up dying. I want to give you a very good example. I've worked in Kenyatta National Hospital Critical Care Unit from the year 04. And I want to tell you, we struggle so much when a patient comes from theater. If you come for a night shift, the whole of 14 hours, you are on your knees, measuring urine, measuring blood, every drop of fluid that is coming from the body of that patient who has come from theater. And we struggle. The doctors don't sleep. And we ensure that that patient who has come from open heart surgery has recovered. Good luck, 7 days, the patient is taken to the ward. And we are very happy we have done a good job. And after another 7 to 14 days, the patient has improved quite well and is discharged to go home, Your Excellency. But do you know what? The bill is 2 million. Where do these people get the 2 million? The NHIF cannot cover the whole bill, and so it covers just a portion of it. So what happens? We retain those patients in the ward. And do you know what? Because of the congestion in these ones, we put those people on the floor. They start sleeping on the floor. How many days can you sleep on that floor? You will sleep there for 1 day, the second day, the third day, you can't even breathe. Your chest is already congested again. And what happens? The patient that we struggled so much in ICU, for all those days, the patient who was well in the ward ends up getting reinfected. And do you know what? We have brought back that patient in ICU, and the patient dies when we are resuscitating. That is basically the scenario and the pain of healthcare providers. Your Excellency, kindly, as I finish, make sure ensure that in your government, because I know we will pray for you as healthcare providers, you ensure that you nominate a few healthcare providers in Parliament so that we will come to help you ensure that the issues of healthcare are well articulated, Your Excellency. And I stand here to confirm to you that these healthcare providers will be behind you. And now it's my humble pleasure to invite the General Secretary. Is he around? Yeah, Mr. Panyako of the Kenya National Union of Nurses. Welcome, sir. Thank you very much.
Maybe before you leave, I want to say this, that a lot of the health laws that are brought by government, including the NHIF, are not addressing the issues that you wanted to be addressed. They're busy removing unions from key positions in the health sector. And that's why we were keeping them. So when the health professional sitting behind me write to me that these are not the right laws, the only way I can help you is to keep the law pending in Parliament. So don't blame me, and I'm sure we are going to do it. So I was saving you sometimes to make sure that the minister's business was just to remove you from critical bodies we felt that affects the men and women who are sitting behind me.
Wow. And that is why when you are appointing, Kaidre, you can appoint some of us, and we will be able to articulate the issues of health in Parliament. Thank you very much, sir.
The Deputy President, His Excellency Dr. William Samoei Ruto, Party Leader ANC, Honorable Musalia Mudavadi, Party Leader Fort Kenya, Honorable Papa Waroma, due protocol observed. Good afternoon. Indeed, I hope the Speaker was just left will be one of those who will be nominated to Parliament. Your Excellency, I have been following these proceedings as I come on my way, and I've had some of the questions, the issues you have been raised. And one of the issues that has been raised is what has county government been able to do that is good and that should be maintained. It is very good when we critique a system, we look from the both sides of what that system has given us. I will begin by saying the good things about devolution. Devolution is good. It's not bad. We must agree. For example, the areas where devolution has improved in the health sector is the issue of increase in healthcare facilities. We have seen tremendous increase in healthcare facilities after devolution. Of course, that is the area where many politicians, especially the governors, will want to see structures. And they'll want to see the electorate that, look here, we have a facility here, we have constructed this, we have constructed this, but that facility is not enough. There is what goes into that facility to make it a functional healthcare facility. Another area that the county governments have tried is to increase the number of basic healthcare workers. I will admit that at the national government, the last hiring that took place before devolution was 300 nurses across the country. Machakos County government alone hired 800 nurses in 2017. And that must be recognized. Another area that the county governments have done very well is to increase the number of equipment through the management medical equipment scheme. We have many equipment, many hospitals, at least 2 hospitals in every county have those equipment. Also, again, the problem comes with the human resource, which I'll come to it later on. Now, as a healthcare leader, as a trade unionist, what are the challenges that have come along with the devolution that we think need to be resolved? Because every time we mention about the Health Service Commission, all the governors will come gun blazing. I will not be mentioning the word health Service Commission, but I'll be mentioning the areas that I think should be addressed. And if in the process of trying to address this issue, the solution will be the healthcare system, so be it. One of the area, Your Excellency, when I came to my office this morning, I got a brief from my employees, and I was told that there was a strike in Embu that ended over the weekend. And I wanted to know what it was for, because I was not even aware as the General Secretary. And they told me all health workers, doctors, nurses, clinic officers, physicians, everybody had gone on strike because Embu County government has not been remitting statutory deduction for the last, 1 year or so. It means those health workers cannot even access healthcare services because the NHIF deductions have not been remitted. And the strike ended over the weekend after the courts gave the orders. So what are we saying? We are saying that health workers have gone on strike so many times, not because they want salaries to be increased, but because salaries have not been paid. We have some counties where salaries have been paid and others have not. So many of the 85% of the industrial action in this country have been occasioned by non-payment of salary in most of the counties. Non-remittance of statutory deductions. There is also the case of discrimination occasioned by tribalism, nepotism and clanism that has already been explained, I think, by Dr. Thuranira. I saw it online when I was coming. Funding of healthcare remains a major challenge. For example, the Constitution requires that every health facility in Kenya must offer emergency health care to every Kenyan or every person who goes to that facility, for example, after a road accident. But the question is, who funds this emergency health care? You come to my health facility, a private practitioner like Dr. Timothy Olweny, and you have an accident and you go there, he is supposed to give you emergency health care until you stabilize. Who is going to pay for this? We must have a system where a fund is developed, regulations and policies are put in place so that emergency health care is funded. We also have a challenge. When the primary health care was destroyed, and it has now been replaced by community health volunteers who are now taking care of the functions that were taken off by public health officers. You know, when I was a small boy, my mother in the shop there would say, "Mtu wa porafia anakuja na tutafunga mlango." The shop must be closed so the mtu wa porafia asishike mama. I didn't know that the porafia person was to make sure that we have a toilet, our place of work is clean. So that responsibility has now been taken over by the community health volunteers, who we recommend strongly that they should now be turned into community health workers and be paid something for doing that noble work. We have heard explanation on how health care is suffering in terms of specialized training. County governments are employing basic healthcare workers. Those, if you're a nurse, you have a first diploma or a degree. If you're a doctor, they're employing with a degree. But when it comes to specialized healthcare workers, is where you have a challenge. That has already been explained, and I need not to repeat it. We have also had the issue of lack of medicine, has probably been explained. Unequal promotions. I'll give you examples of two counties that have done very well. When you go to Kiambu, our union has spearheaded at least 4 promotions from the day devolution took place. But in other counties, we have 0 promotions. So we have health workers in Kenya who are enjoying, like in Kiambu, and we have other health workers elsewhere where promotions has not taken place. Because these are the issues that lead to disruption in healthcare services. So how are we supposed to address these issues? I've heard somebody say that centralized system is not good for the country because it has failed before. Why do we have the Teachers Service Commission having teachers working everywhere in the country? Why? Why do we have national schools in Mandera? Why do we have national schools in Wajir? Let us not try to paint health workers as if they do not want to be managed. We do not want to manage ourselves. We must have to resolve the issue of strikes related to non-payment of salaries and non-remittance of statutory deductions. Let us have a centralized system of payment of salaries to all health workers and indeed all public servants. Because it's not only health workers who are suffering at the county governments. It is all public servants at the county governments who are being reduced to beggars. Today, we had the central bank say that it has billions of shillings that have not been taken by public servants through mortgage and car loans. Why? Because county government employees are not classified as public servants. So they cannot access mortgage and car loans, which is only 3%. So after devolution, these health workers, you see, are now just getting expensive loans like any other millionaire outside there, making their lives very, very difficult. So for me as a healthcare worker, if you give me a centralized system of payment of salary, a centralized system of allowing county governments to give out the specs on the employees they want, you, County A, give out the specs as the health system, as the, whatever it is, the workers you want, pay, employ them. Once you employ these workers, offload them into that system. Even if you have the Health Service Commission, as we have been saying before, of which, if we can get our salaries on time, statutory deductions can be paid on time, and there's a system where health workers can work across the country seamlessly. For example, Wajir County wants to have a neurosurgeon. It will simply release that specs to the hiring authority and say, we want a surgeon in Wajir. And whoever is responsible for hiring, I told you I'll avoid the issue of Health Service Commission. Whoever is hiring will post that surgeon to Wajir. Whether the surgeon being posted there has been hired today, or one is being removed from Kakamega and being taken to Wajir, and the one being hired is being taken to Kakamega, what is important is we must have a surgeon in Wajir. That is one of the suggestions I'm trying to say. But the issue of salary, statutory deductions, discipline is another area you have said that we want to manage ourselves. How are teachers managing themselves in terms of discipline? We will give these powers to the county governments to be able to identify and give some disciplinary measures, because we know the issue of tribalism, nepotism, and corruption at the county government level. We want to remove healthcare system from the political system to a professional system. But there must be some level of where there is regulation. We are not trying to say that health workers must work when they want. You cannot work when you want. You must be on duty when you have to be on duty. But if you are not working, the county government can be given powers to stop your salary, remove you from employment, and wait the body responsible for a disciplinary process to take its course. And if you have to be dismissed, you can be dismissed. So we should not use scapegoats of saying that health workers want to control themselves, they don't want to be managed, to deny Kenyans healthcare services. We have gone on strikes for so many times, and Kenyans have not benefited from devolutions because of the services the health workers are supposed to get are not getting. Imagine today in Kiambu, in Embu, health workers in Embu cannot access healthcare services they are giving to the citizens. When you go on strike, they will rush to court, get orders, will go back to work. Nowadays, we are respecting court orders, because if you don't respect the courts, then the country will be in chaos. I think that's all I can say. If what will solve these issues will be the Health Service Commission, so be it. Thank you.
Yes.
Mzuri sana, Mheshimiwa.
Thank you for your presentation, Seth. We want to look for solutions. And as an incoming, we want not to have, we have so much tension and downing of tools by such a critical sector. You are non-committal on the Health Service Commission. Now, can you help us to understand under what arrangement can we have a neurosurgeon within the context of devolution moved from Homa Bay to Kiambu or from Mandera to Nakuru and vice versa. How do we engage legally the devolved units to surrender their staff who are on their payroll to other counties? Number two, I don't know if nurses also take the Hippocratic oath, but doctors do. You know, when teachers go on strike, the children and students can be taught another day. But when healthcare providers go on strike, people seeking emergency services cannot wait for another day. How do you reconcile your Hippocratic oath with now the trade union activism that we see of doctors downing tools, people coming for emergency, they can be treated, they end up in private facilities, they can't afford, and so on. Number three, what would be your thinking? You know, we have had this in the Senate, that perhaps if we do not want to change the constitution because the mood in the country has not been in that favor, we try and persuade the national government to open referral facilities in the regions. They can cluster regions, and where possible with big counties, they can give them those facilities so that they can continue having those professionals and serve wananchi in the manner that we expect. But short of that, perhaps a center that can be able to have a bird's eye view over the health system in the country to move personnel is an idea that is not too bad, as long as we balance it with devolution, because the people of Kenya voted for this constitution because of devolution.
Thank you very much, Honorable Moses Wetangula. The first issue about how we can transfer health workers from one county to another county. I did not say I'm not supporting healthcare system, the Health Service Commission. I said I'll remain uncommittal because my brother who spoke earlier had already spoken about it. And when governors hear the issue of the Health Service Commission, they just imagine that we want to go back to the national government. They don't know that the Health Service Commission is independent of the national government and is supposed to be independent of the county government in the form of being controlled politically. I have said a conversation must be opened. And I've said the issue that I've raised, for example, on transfer of health workers or redeployment of health workers from one point of service delivery to another point of service delivery. And I've said, if this conversation will end up saying that the only solution is the Health Service Commission, I said, so be it. So I did not say Health Service Commission should not be there. Why do we have a Health Service Commission for teachers? And yet we have national schools in every sector, in every county of in this country. So that one can be done. I can't give you an answer. I've said, let us open a conversation. And if the only solution will be the Health Service Commission, then let us revisit our constitution. Our constitution is not cast on stone. It can be amended. The issue of number two, the next issue was if nurses take hypocrite oath. No, we take the Florence Nightingale oath. And that is, the nurses are the only profession in the world that have a convention, which is a convention number 149. And along that, we have a regulation that governs industrial actions. And the convention requires that when we go on strike, we ensure the welfare of the nation in terms of health is not compromised. How do we do that? We must have a collective bargaining agreement that tells when you go on strike, these employees will not stop working. For example, you can't go stopping ICU machines from patients saying that I'm going on strike. Those are issues that we require to have a broader way of discussion. The last question was about Mheshimiwa. I'm just trying to tell you that we don't remove nurses from ICU. For example, we don't go tell mothers in labor that leave. We go and we take care of the patients who are there. We don't leave them to die. That is what the ILO Convention requires of us as a profession.
Excellent. The last was whether an expansion of the referral services system in the country would help address your issues. And in addition to that, even counties are covered under the Constitutional Commission, the SRC, the Salaries and Remuneration Commission. Has your union ever engaged them to see whether the provision of mortgages and car loans and all those issues you are complaining about can be extended to services being provided in the counties? Because I see MCS in the counties have access to mortgages, have access to car loans, courtesy SRC. Have you engaged them?
We have done all that. I'll be very short because His Excellency will have come and speak. We have tried to engage. We have engaged the Public Service Commission. They're amending the definition of public health service, or public servants to include county government, but that has not been done up to now. On the issue of the healthcare system, we have talked so much about this. The health referral system began way from level 3. And it was dismantled illegally because the Constitution of Kenya never dismantled the referral system. The referral system was dismantled illegally. Thank you.
Thank you very much, Mr. Panyako. I know you have a lot to tell, and we'll appreciate that. It is now my humble pleasure to welcome our chief guest to give an oversight as we progress. We still have more time, and that is our Deputy President, Karibu Sana. Please, let's be upstanding.
We don't have to stand. You don't have to stand, please. Why are you harassing people? We were all doing fine until you brought the standing up thing. So, listening to the people who have already spoken, we are actually having a conversation of our lifetime. I think David may have underestimated what he said earlier about the importance of this conversation. I see the passion in everybody and in what they are saying. And it goes to confirm that this is one conversation that is a must-have. And this is one subject that must be, will be a must-do. Listening so far, and I'm going to give way to another 3 or so presenters. As I said earlier, and now it has been confirmed by what the speakers have said, is we finally must get it right at the dispensary. We must get it right at the health center. And we must get it right at the bottom of the pyramid. The crisis we have today in our referral facilities is because there is a shortage of health professionals at the dispensary. There is no drugs at the dispensary. And it will cost us less. It will make it that much more accessible if we made it available at the bottom of the pyramid. And that seems to be what you as professionals are telling us. The second item that I am picking from here is a health management system, an electronic, so to speak, health records system, so that we avoid the duplication that is going on. You go to a facility, go to MRI. You go to the next facility, go to MRI. You go to a hospital here, go and take these samples. We can reduce significantly the cost of deploying our health by making sure that health records are available. We just need a mechanism, and it is not rocket science because it's done by other countries, of making sure that there is health records confidentiality. Outside that, there is absolutely no reason why we must not have electronic health records that are portable, that when you go to a health facility in Korogosho, and tomorrow you go, or next week or next month, you feel sick and you go to a health facility in Nakuru, the doctor or the health professional in Nakuru should know what you are diagnosed with, the kind of treatment you were given, and then begin from there to figure out what can happen next. That way, we can bring down the cost of delivery of our health programs. And I want to promise you that this is one item that we must sort out. In fact, we had gone as a government a very long way in acquiring this health management system complete with health records, an electronic health records program, but because of conflict of interest and many other issues, it wasn't possible. This is one deliverable that will reduce significantly the cost of supply of our health services. Number two, or number three for that matter, we must have a competitive, transparent, stakeholder-driven procurement of all our health commodities. We just must do it. It's been done in the energy sector. We have some of the most competitive oil prices because of the nexus between the private sector and government in the procurement in that sector. We can deploy the same in the provision of our health commodities. I spoke to a doctor, and we are currently buying health fluids, the drips we have, and which is 95% water. So we are basically importing water from other countries, and we are paying for it. I think it's time we went down the road and make sure that we scale up our manufacturing locally. The reason why, and it must be deliberate, manufacturing locally of pharmaceutical commodities must be informed by our desire to create local jobs. And it must be possible for us to produce many of these facilities locally. I told you earlier, I don't know whether it's by coincidence, I was speaking to one gentleman yesterday who produces medical supplies, medical commodities. I will not mention which ones, because I don't want them targeted. And he told me that he supplies everywhere else from Mombasa except to Kenya. He can supply his commodities, which are manufactured in Kenya, to all other facilities, including in far-flung areas, but he cannot simply access the Kenyan market. And that is a Kenyan producing in Kenya, but cannot access the Kenyan market. We must be, and that is primarily because of the cartel around KEMSA and the whole of that space. So we must break the cartel and make it possible for manufacturing of pharmaceutical commodities to happen in Kenya so that we can get quality, as has been asked here. We can control quality more, and we can control also accessibility more. These are among the items that so far I have picked. We're still sitting here, all of us, and the remainder of the speakers, we would like them to focus. We've heard from our health practitioners the need to balance the success that we have achieved in devolving health to the counties, and I like it that even health professionals themselves admit that there's been some success and progress made, and we now need to balance that so that there is no tension between the doctor and the patient. We need to harmonize, we need to create harmony so that the patient has access to healthcare, but also the doctor is working in an environment, or the health professional is working in an environment that does not undermine their own progress and that not undermine their own well-being. So that is, I think, the balance we need to create. And I agree that health being a matter that keeps evolving, continuous training, continuous progression is necessary, and there must be a mechanism. I am aware, sitting in IBEC, that many counties are grappling with a doctor who wants to go for further studies and requires a scholarship, and the county saying, we can't allow you to go train more because we don't have the money to hire somebody else to do what you have been doing. So this is the tensions we need to resolve, and I am hopeful that by the end of this conversation, and having listened from across the country, we will finally come to a fair balance that will give us the thrust to move healthcare to the next level. I also want to say that the big subject of the requirement of the Constitution that every health facility, wherever they are, whoever owned by, must provide emergency service. That constitutional provision must be met. And therefore, there is need, and we are going to have a conversation on how we are going to have an emergency fund that is going to take care of those incidences when they are provided. I think it's the only reasonable way of making a demand from every facility to provide emergency service, because then they know that somebody is going to pick up the bill. But if it is left to nobody, then it gets very difficult for facilities to provide emergency service, which could potentially save a lot of lives if they are attended to. So again, I think it is time in our journey as a nation to provide for a health emergency fund that will take care of those kind of incidences. Having said that, I think, my good brother, you have the floor.
Thank you, DP. Honorable William Ruto, and Honorable Mudawadi, Honorable Wetengula, and David D, and all the leadership of Kenya Kwanza. My name is Dr. Amit Thaka. I am the chair of Africa Health Business, the founder of Avenue Healthcare, and I'm also the current chair of the Kenya Health Professionals Oversight Authority, the first authority under the Ministry of Health to bring whatever good colleagues have mentioned about the health professions. This first authority hopefully will try and spur what you call harmony, like you said, DP, amongst the profession, which has achieved a lot. I want to share my experience having trained at the University of Nairobi with my internship at Kenyatta National Hospital, worked in the government system before I started my own company with 2 staff, Avenue Healthcare, which has now got, over 1,000 staff, and present in over 13 counties. My own personal experience in providing health services and systems. Of course, I have a bent to private sector, so I'm going to talk a little bit about that. But I want to be solution-oriented, and I want to share my experiences in 4 areas that I've seen Kenya Kwanza discuss this amazing discussion on health. So I want to first congratulate the Kenya Kwanza team. Let's give them a round of applause. I've been to many forums, including discussions indoors and boardroom. DP, this is a good one, and I hope you keep it going. And I don't think this is the end. I have heard from Timothy, I've heard from Simon, I've heard from Seth. There are many issues which cannot be really discussed in one day, but I hope it carries on. Let me first say and congratulate the Kenya Kwanza team, because the documents that I've read are fairly balanced between what I consider 60-30-10. I've analyzed your document to be a 60-30-10 document where you're giving a lot of focus on primary healthcare, and that's fantastic. I have witnessed in about 60 or 80,000 patients that we see, 70% of the patients that walk into the doctor's clinic come with preventable illnesses. So if you spend more focus on the preventive and promotive care, which I'm seeing you're giving about a 60%, that's great. I know, David, you're talking about a 30% on the secondary care, and you're putting 10% on the tertiary care. So this pyramid approach, which is almost mirroring bottoms up, and the bottom is literally prevention is better than cure. But it's also cheaper than cure. You agree with me, the people who are in the profession. I have the privilege of also working around Africa and moving in health systems to at least 15 or 18 other countries. I've set up hospitals in 5 other African countries. Kenya is at a very good advantage, DP. To be honest, let's also celebrate our success as Kenyans. Let's not always call everything doom. If you look at when I started, the life expectancy of Kenyans has gone up. The medicines and availability has gone up. The number of doctors and health professions have gone up. Awareness about maternal mortality and infant mortality have gone up. The number of CT scans have gone up. The number of ultrasounds have gone up. So I think we should first give ourselves a round of applause. I mean, for the work that we have done, but there is a journey to go ahead. This country is different from the other neighboring countries because it has 3 strong pillars of healthcare. And in the 100 days, DP, that you have, and all the systems that David and the team are putting together, let's make sure that you are the government of all the 3 systems, because these 3 pillars are important. We have the public sector pillar, which is quite heavily tax funded, and we want to strengthen it. Then we have the private sector pillar, which is also the pride of East and Central Africa. Anybody with a dental problem in Uganda or in Congo, they know if they're in Nairobi, they're safe. In fact, many expats want to move here and settle because they know they'll get good health care. And thanks to the private sector, we've been investing. And the third pillar is the subsidized pillar. Let's not forget the good work that the NGOs and the faith-based organizations are doing. And I really want to give them a round of applause with the church system and all the faith-based organizations across the whole country. We do collaborate a lot. So I think the three-pillar system must be looked after as we look at all the important areas that we've discussed since morning. I know the first 100 days are important, and I think I also want to stress that health takes time before you see changes. I don't think it's immediate. You know, when you open the expressway and then people just drive, it's like immediate impact. It takes time. Health, you build over time. Health professionals, you build over time. So if you have a long-term plan of 4 or 5 years, you will see health of women, children changing. But you do want to make impact. I would like to suggest 4 areas that this country might find health completely changed in 1 year of your administration. The first one is commodities. And many of us, we know that if the commodities are managed effectively and appropriately, the cost will go down. I support your stakeholder engagement. And I know the petroleum example that David used, most people in healthcare find this competitive overlap in the stakeholder engagement a bit tricky. So how you bring multinationals into that stakeholder and local manufacturers and distributors, I think we'll need to balance it. But I fully agree that where you buy from, how much you buy from, is going to change how much counties are going to be ending up paying. Why should I, in my hospital, when I buy just, say, 5,000 units of antibiotics, pay less than when KEMSA is buying, when they're buying 500,000? Economies of scale should make KEMSA the best buyer of antibiotics. Yet I can buy it cheaper than them from a local manufacturer. Why do the numbers not add up? And if the saving is passed to the county budget can go much longer. So I think there's a lot of work to do in KEMSA. Let's not throw the baby out of the bathwater at the same time. Let's fix where the gaps are. Let's also fix where there may be self-interest. But KEMSA should be able to provide a better price. But DP, let me say one thing. If we decentralize purchasing at 47 counties, one of the worries is where they would buy from. And the market here, unfortunately, when you open a container sometimes, when there's mitumba and you remove the clothes, at the back, there's a whole load of drugs. Ciproxine, Augmentin. So some people still bring in drugs that are not fit for Kenyans because of the loopholes in the whole system of bringing counterfeit and irregular medicine. KEMSA is happening to give us quality drugs in all the counties. If 47 purchasing units start opening up, the only worry will be, will they start buying poor quality of drugs for the counties? And that may damage the healthcare system, even if we have good doctors and nurses on the ground. So I think commodities is a big one. The second one I want to talk about, which I know you can make an immediate impact, is healthcare financing. And the whole idea, we spoke about risk pooling. And there's been a lot of system, should we have A or B, or should we go for 1 or 2? I think we should have a mixed model of health financing. Let me explain a bit. You know, United States spends $10,000 per capita, per person on health. In Europe, they spend $4,000. We're not yet there. So we also need to be cognizant that our entire budget for the health sector is about $150 per capita. Now, there is so much we can collect from everyone who will be able to pay. Majority of the people are not able to contribute to become an NHIF member. You know, like Timothy said, he doesn't want to use the word indigent. So let's say those who are economically challenged. And the bill to you to make them members might be high. So could we, in financing, again, support both public risk pooling and private risk pooling? And you've mentioned it many times. And if you can contribute to NHIF according to your salary scale rather than just a fixed 1,700 shillings, and it is pegged on salary, we could be considering it as a levy. In addition to that, you might not want to burden the public health system and you still can afford the private health system. So my question, honestly, to you is, could we continue letting those who can afford private care use private facilities and leave the public facility for those who would prefer to have a publicly funded system in the beginning until we look at a more national system? So my view is a mixed system is better. When we introduced free primary education, you remember many parents were excited and they went taking their children to school. But many of the people in this room are still paying for private schools for their children. And that was good, because whenever you took your child out from the public system, you left a chair for a child who would not afford education in that school. So in the same solidarity principle, in health financing, I am also fully supporting your idea of splitting NHIF to make it more efficient. You know, we've always said, if you continue doing what you do, you continue getting what you're getting. I'm beginning to hear your structured approach, which is actually a global standard of how social health insurance is managed, where you have a different arm collecting the money, which is the revenue pool. You have a different arm that will be interested in accreditation. Hospitals, clinics, you accredit, and there's a different arm settling claims. When you have the judge and the jury in one state corporate, we get what we get. And this is why we're having inefficiency losses of the $500 million, which I hope should go to $1 billion of risk pooling every year. The third pillar I want to talk about is the pillar of human resources. Kenya is endowed with youthful, English-speaking, smart professionals. We should be taking advantage of these and try to have e-learning systems in place. I realize that the number of people who want to become health workers is far greater than the capacity at KMTC. The admissions that are given, and some of the limitations are infrastructure and faculty. So let's start producing health workers, invest in our faculty, start introducing e-learning, which has been a major way where we are having more health workers coming through, and partner with other institutions to have this CPD and quality of learning that keeps improving. Our partnerships with the global community is pretty good. DP, recently we sent nurses to the UK, which was great. It was a testament. Now, obviously, some of them were told you have to learn English before you come back to UK, and that English was more like, you know, understanding the culture. So there are things that are to be taught in our campuses that need to change. We need to be fit for purpose. Our style and curriculum of yesterday is not fit for tomorrow. We need to understand technology. We need to move from stethoscope to keyboard. We need to have collaboration and patient engagement. I feel we have the best time for human resources for health, like Philippines did many, many years ago, and had a bilateral arrangement. So that's going to be impactful. The fourth one, I think you touched about it, and I think the fourth pillar is digital. And I think you are also so passionate. You make sure you don't miss that point when you talk about it here. I think we should start exporting our telemedical services. Do you know, for many, many years, India had export compensation for pharmaceutical, and we got many packaged medicines coming in. And they've got the trade right, and they're doing it right. They've got that. But recently, they have started introducing digital health and telemedicine to be sold to the rest of the world. In my own office, I have received Apollo Hospital, I've received Manipal Hospital, and you know what they're coming to sell? They're saying, hey, you know what? Your digital films of X-rays, ultrasound, send it to us. We can report it 24 hours. I'm sure many of the health professionals here know what I'm talking about. If they have started doing this, let's beat them to the game. We go to Congo, right? We go to Ethiopia. Let's get the licensing right, and we start selling digital health services, not only for export, but it'll also help us with the electronic medical records that you've been talking about. Once we get the backbone or the architecture of our digital services in place, I think everything else will follow. I'd really celebrate you if you can get that done in the first or the second year. So this is just my own experience that I wanted to share. I hope it's been useful. Good to see you, Stanley. Thanks.
Thank you. One moment, Thaka, sorry.
Yes.
Let me go to healthcare financing.
Yes.
Because that's really the elephant, you know, in terms of where we are today with NHIF, the public deployment of resources, private health insurance, and the whole of that scale. As has been said here, last year we spent in total, public, out-of-pocket insurance, close to 550 billion on health. Now, when you say we need a mixed system, you say those who can afford private insurance should continue, should be allowed.
Yes.
And then the people in NHIF should go to public hospitals. Isn't it possible to make it seamless and continuous? Isn't it possible for us, for example, to say, if you are on a private insurance of 80,000 a year,
Yeah.
it's possible for that private provider to cede whatever it is, 20,000
Yes.
of the 80,000
Yes.
to NHIF.
Agreed.
To provide the base.
Yes.
And then the next levels of engagement, as you climb up the ladder of health provision, then the insurance can pick it up from there. So that we do not have two sets. We have one set, but it is continuous, seamless, but structured.
I see.
Don't you think
it's a good suggestion. Let me give you a collaborative proposal. Let's say I'm paying 80,000 for private insurance and I give a levy of 20,000. I want to just use your same argument. Or let's say I call it the fee. And we have, say, 3 million people in private insurance here. And if we divide it by 47 counties, that amount of money that we could get from them as a levy could help 47 counties sponsor the people who are not members of NHIF. So, you know, what I wanted to think of, I don't know the exact numbers, but something that I want to speak with David. If we got enough money for the people who can afford, in a county there are two types of people. There are types of people who are employed and are members of current NHIF, sorted out. But DP, there are many people who are not members of NHIF. To me, that's your priority. A country will be judged by the people, by the system that looks after the vulnerable. How do we get the people who are not members of NHIF to be covered or to get care? And the dual system I was thinking of was, you were saying let the basic be the standard and then let it be a continuous system. That's one approach. The second approach is Let it be separate systems, both public and private. I also want NHIF members to go to private. Let them choose. In fact, let them vote with their feet. That way the public sector will become better. But let the private sector pay a certain fee that will help many of the people who are not members of NHIF to get a fund. 47 counties. I'm trying to figure that out. And so we have more people who are covered and are catered for into the system. And those who are not members will end up going for primary health care anyway, which is tax-funded system. If you make our clinics fantastic, like you said, dispensaries, so there's no lack of doctors, where you are looking at health centers, believe me, you will put pressure on the private sector. Because as government pulls up its socks, we have to pull up our socks. And the whole system will go up. Sorry.
Okay, maybe so that I can give it to David. I would not, Thaka, I would not go for the people who are paying private. I would not want them to pay a fee to NHIF to take care of indigents. No.
Okay.
Because we do not want to burden people unnecessarily. The public sector provides the base, and the base is available for everybody, right? What I am looking at is we want a seamless health provision, seamless, so that, but everybody gets a piece of, especially the people who pay private insurance. They should make their contribution like everybody else.
Agreed.
And benefit from primary health using NHIF. Right? And NHIF will pay to the extent that everybody else on NHIF can get. And then from there, we can then make sure that they can benefit, but it has to be seamless. Maybe David can help me explain better.
Let me elaborate so
Yes.
that Ramit can react. Okay, let's throw some numbers. The thing we want to sort of react to, and you're the best person to react because you run a private MO, correct?
Correct.
Now, we're trying to solve, let's first say 550 billion.
Yes.
Contributed as follows. Government and donors, 350. Insurance, including social and private, 50. That's NHIF and private. It's about 10%. Okay? 27% out of pocket, 150 billion. So we then do, but we say, things per capita.
Right.
Or because we have 12 million households, it's 55 million shillings per household. 55,000 shillings per household. So we look at it and say the following. The government is spending 7 shillings per person. Or multiplied by
5.
Yeah.
35 per household.
Per household. Government is spending 6 to 7 shillings per person. Then per capita on insurance, social and private, is 1,000 per person. And then per capita out of pocket is 3,000 shillings per person. We're saying now, would it be possible, if it's 3,000 per person, which works out actually to something like 12,500 per family. Plus the 1,000. So would it be, actually, if you exclude the government and donors,
yes.
If you take the rest, what we do in Harambes, plus what people have paid in insurance, it's 4,000 per person. It's actually 16,700 per family. Is it unrealistic, instead of us paying out of pocket, and I've just made a contribution on my phone now.
To have a contribution paid.
I have just made a contribution of 6,000 shillings
Yes.
for a medical bill.
Yes.
As we are sitting here.
Yes.
Instead of doing that, is it possible for us to do one annual harambe
Yes. And collect this.
and collect these
into a pool.
150 billion
Into a pool.
and put it into that pool?
My answer is ready.
The-
I have an answer, David, for you.
now, this is the thing.
I love the question. I have an answer.
Yes, but let me say this. How do we, when talking about seamlessness, we think, now, if the government is paying 6,000 per person,
Yes.
can the government just pay for primary
Okay. I like that question.
by whatever model? So government just pays for primary. Let me come to where you're talking about parallel. And then, because we've already made social insurance mandatory through NHIF.
Yes.
So the question we have there is, once we've made it mandatory, can we make enrollment universal? That becomes the question. How do we make enrollment universal?
Universal.
And if enrollment is universal,
Yes.
how do we give people choice so that we accommodate private?
Agreed.
So the question then becomes, could we make the two stack on top of each other so that social sits here, and when we have done a bit of math, we have said if you graduate, instead of saying it is 3,000 per person,
Yes.
we did some math and realized if you graduate,
Yes.
it can be between 300 and 3,000 per family per month.
Wow.
And that would raise, there's a way you can do it, and it raises 200 billion shillings. If we could enroll everyone.
The problem, I love the question.
The question is enrollment. Now that's where I'm coming with private health care. Could we allow people in private insurance to be enrolled by their insurer?
Yes.
So that instead of you paying twice, when you talk about seamless,
Yes.
instead of you paying twice, can your insurer enroll you in the social for the tariff that you should pay at your income? Okay, so that it becomes a collector.
Agreed.
And then, when your insurer covers you, so that somebody, the person you've covered, they have been enrolled for, their family is entitled to 20,000. They're enrolled for 20,000, and they are entitled to 50,000 shillings worth of service, or 100,000 shillings.
Yes.
But your insurance
Yes.
is for 80,000, and it entitles them to 400,000.
Yes.
System where you enroll them.
Yes.
And then once their claim comes, you recover what they are entitled from the social, and you pay the balance yourself.
Yeah.
That's what you're calling seamless.
I like
Is that something that we could work towards?
Yes. I think it's workable because even in the private insurance, there are ideas of co-payments and capped payments. So you are saying you are capping. So the first risk is taken by the basic cover. Enough. And then anybody else who takes a risk above a certain amount, the private insurance kicks in. So it is seamless. But let me do a survey for you, David. Just here. In this room, we have many people. My view about all we are talking about is trust. It's trust. I think Kenyans are finding the issue of prepaying. There's a lack of trust. We have to build trust. Let me see by show of hands, how many of us trust paying NHIF? You trust your money is safe. How many of you don't trust NHIF? Have a look. DP, have a look. See these numbers. This, if you go to the ground, people don't have an issue of becoming prepaid, the 27% you were talking about, David, and how you can make it between 200 and 3,000. The issue is when I give my money to a state which is taking a fixed fee, when it comes to give me benefits, will they give me? So we have to improve awareness. I'll be honest.
Let me intervene and ask the following question. Can we take the social insurance away from the state? Quote unquote. Not a finish.
I don't know.
No. Let me finish.
Yes.
Because you're saying, how do we build trust? I'm asking.
Yes.
I'm actually now going to the trust question.
Yes.
How could we change its governance
Exactly.
so that we
Exactly.
trust it? If
Yes.
if we did the unbundling and put the fund somewhere
Yes.
else,
That's what you are
could
planning
we
to
put
do.
the fund in a place where we are sure it is safe? For example, the way we do it with pension funds.
Yes.
I manage a fund, an asset management company.
Yes.
With all these Chinese walls.
Correct.
And we have CMA on our case every day. We have RBA on our case every day. Could we go that route so that the fund sits
Please
somewhere
That's what we
where
are.
it is safe?
I'm supporting you for splitting governance of NHIF to make it a stronger institution. I'm not saying this institution is, I'm saying if you make it stronger, the people who raise their hands here, they will say, now if you are collecting 200 or 2,000 from my family, I don't mind.
Okay.
At the moment, the issue is not the money. The issue is, will this money do what the government is saying it will do?
It will do.
That is the issue. It is not the money. The money is the smallest thing.
The trust.
It's the trust. If you show Kenyans that you can create trust, believe me, forget 200, we'll pay 2,000 and we will make a social insurance happen.
I think point very well made in terms of, I think the seamlessness is answered, and you have brought in the biggest component, which is trust.
Yeah.
And I think the reason why we even went all the way to making it compulsory is because not too many people were coming on board.
Correct.
Now that it is compulsory,
Yes.
then there is no other option but to make it work.
Correct.
And to make it work is to make the systems there work better.
Correct.
Do you think, in your judgment, automating, what can ICT do? How can we leverage ICT to build more trust?
I totally agree. If I go to the NHIF website today, has anybody gone to the NHIF website? Anyone? Type your number. Do you get any data? So there's some simple, Yeah. Do you get newsletters from NHIF as a member? Do you say, thank you, member, for big, because Jubilee sends you that. Jubilee tells you what is going on, because you know what? Jubilee wants renewal rate. At the end of the year, if you don't like Jubilee, do you know what you do? You move from Jubilee to? Yeah, you just move. With NHIF, you remain there whether you like it or not. So DP, what we need to do is we need to delight our members. IT, ICT, customer service relationship can improve. That's one. But also red alerts on where the leakages of fund claims administration system. To be honest, that's what it is. The whole insurance world, you know, in India, it's illegal to run your own claims as an insurance company. You're not allowed. You have to, by law, give it to a separate claims administrator who has a fixed fee called 10% of your premium. That's the cap. So I agree with you. We need to put an ERP in place. We have to put a claim system in place. We have to put a customer interface. We as Kenyans will know the day NHIF has become more tech savvy, because it will start communicating with me as a member. I have a hard time receiving And I'm not very happy about that. I do want our customers of NHIF to be happy. And let's make them happy by giving them what they want.
Thank you very much, Amit Thaka, for your insights.
May I just
one moment?
Yes.
One final one, just as an observation. Mr. Thaka, one of the issues about trust simply boils down to an experience of NHIF and indeed even the pension body.
Yes.
The welfare body, NSSF.
NSSF.
The investment, the losses that have gone from previous investments. Do you want to say anything around?
Yeah, they should not buy hospitals. They should not put up too many buildings. They should not put money in a bank that was going bust. But I agree with you. If the investment committee in NHIF and NSSF are aligned, then they should use the money, which is our money, in the best way for it to reduce catastrophic expenses and help those who are in dire need to pay them beyond the benefits. If someone has a cancer, so I'd love to see the CSR of NHIF with additional funds to help Kenyans in health distress. So my question is, I don't have an answer, but whenever I read the news and what we've seen in the past, the investments haven't been the best. They have been misplaced. Sometimes in, again, like DP says, there could be conflict of interest. And there are other interests there. So how do you end up buying ambulances just before elections and use NHIF funds and move them around? How do you give counties ambulances? There are many people from counties here. There are ambulances without drivers. Some of these ambulances are being used to carry charcoal. Is that wise use of our money? So, yeah, Honorable Mudavadi, I agree with you. I think your question was leading to say that we could be smarter with our investments.
Exactly. Thank
I
you.
agree with you. Thank you. Okay.
Thank you very much, Mr. Thaka.
Thank you very much, Dr. Amin. I will now invite Mr. Tony Kirwa, a representative of referral hospitals. Karibu.
Your Excellency, the Deputy President, the guests who are here, all protocol observed. It's quite a challenge to speak after giants have spoken, but I will attempt, Your Excellency, to speak. You know, speaking after you have spoken is really, and the senior doctors here. But what I will do is, we have already mentioned quite a number of what I had wanted to say. So I will enrich and concretize issues which have been brought here. Last week, Your Excellency, you met people with disabilities, and I listened to you. And we were saying, a country is judged by how much we support the vulnerable. There are no more vulnerable people like the sick people in hospitals. They are very vulnerable. And when you look at how much we allocate, Your Excellency, to health sector, both at the national and at the county level, it's just 4% or less. Rwanda is doing 23% of their budget. So even if we talk about all these issues, and you have always said it has to be very deliberate, we have to be very determined and allocate resources where it is. 20 years ago, Your Excellency, 2001, there was a meeting in Abuja of African Union. And we agreed as nations of Africa that we'll put at least 15% of our money, 15% of our national budget. Now we are doing 4%, Your Excellency. We need to do something about that. Because Malawi is ahead of us, Seychelles is ahead of us, about 5 or 6 countries have met that, Your So if we don't allocate that amount to health sector, then we will be grappling with a lot of issues at the county level and at the national level. We have said we will address issues of NHIF comprehensively. We need the money. I have seen we have belabored the point of NHIF. NHIF remains the, I don't want to say, maybe Dr. will oppose it, but the only silver bullet we have to fight in order for us to achieve universal health coverage. What we need to do is to turn it around. I don't know how we will go about it, but my position is this, Your Excellency, that anything we need to do to help NHIF so that when I go to the hospital or any person or people who are below the pyramid are able to get medication. That's the key thing. How we go about that, that is the elephant in the house. But for us who have worked with NHIF as a user, as a beneficiaries by being treated and helped by them, we have seen they have issues with the human resource. It's a big issue. Go to Eldoret. They are not able to process those issues. Issues of ICT is becoming a problem. And the numbers. You know, hospitals are marketing for NHIF. All of us, leaders in the churches, join NHIF. So the numbers is overwhelming. And we need to find a way of helping NHIF. Now, Your Excellency, with the help of the budget which you will allocate, I'm sure for that, we will really focus on issues of family medicine, family health, community approaches, population health, that will be cost effective and has high impact. These institutions which we are building through devolution and whatnot, we have to find a way of linking them at the grassroots level, from the household up to the national referral hospital. We have to find a way so that they can impact. We have to put a lot of emphasis, Your Excellency, on prevention. We have talked of prevention. We need to find a way of preventing these diseases. Early diagnosis, we have to find a way, and the referral of common diseases. You have asked us whether we need to do something about the referral institutions. Your Excellency, you are aware that we have about 5 or so referral hospitals. The Apex, the level 6, the KNH, the MTRH, the Kenyatta University Teaching and Referral Hospital, Mwai Kibaki in Othaya. Now, when we say these are referral at the Apex, we need to support, totally support, in terms of infrastructure, manpower, technology, talk about anything, so that we don't need to refer a patient from one of the Apex hospitals to another Apex hospital. There is no point of us in MTRH referring a patient to KNH, just because we are not funded the same way KNH is funded. It doesn't make sense. So if we say these are Apex referral institution, let it be seen that they are really Apex. Now, those Apex referral hospitals are not enough, Your Excellency. We need to cluster areas, counties. And we are proposing in this meeting, Your Excellency, that in Garissa, we should have a referral hospital of the level of KNH. In Embu, we should have one. In Machakos, we should have another one. In Mombasa, we should have another one. In Bomet, in Kakamega, we should have a referral hospital. Why do I talk about even about Kakamega? It will really help us. MTRH takes care of 22 counties. It's half of the entire country, from Nakuru all the way to Busia. We are seeing, Your Excellency, 1,500 If you check from the government, they will tell you MTRH is 1,000 bed hospital. Is 1,000 bed hospital. Look at the math. We are admitting 150 every day. Where are the rest being placed? We can't send them away. That's a government institution. They have to find a way to where to sleep. And that's why we're ending up with having 2 or 3 patients in one bed. The infrastructure stopped. I think the government stopped building a hospital with the Nyayo wards in the 80s. Whatever you are seeing in MTRH is out of friends of the hospital. Partners. We are partnering with Mo University, and Mo University gets support from Indiana University, all Northern American University, by virtue of research. And that's where we want to spend more money again, on research. Best practices. Yes. We want to see government, out of that 15%, this is how we will get this support, Your Excellency. So, I'm answering quite an issue so that I will have very few questions from Professor Ndi. And I'm not lucky, the Vice Chancellor not here again to give me the same, what he has given the Deputy President. What I am preempting is that we have talked about they call healthy what, Service Commission. Many people fear to use that term. What we are proposing, Your Excellency, is that there should be a way whereby a doctor in Alupe in Busia and a doctor in Elwak or in Machakos can be brought on board so that their salaries are the same. If it's posted to Nairobi, to NMS, it will earn the same amount. That's what we are saying. Let us structure it so that elder workers can find a way their welfare is catered for wherever they are. So this urge to go to Nairobi will not be there. Because I'm earning the same salary like someone who is in Nairobi if I'm in Alupe. But as long as someone in Alupe, a doctor in Alupe, earns very little money compared to a doctor in Nakuru, then there is that discrepancy and becomes a big issue. We need to address that issue. Now, we have talked about doctors and health workers going on strike. In MTRH, we have found a way. And we hope other institutions can follow it. For the last 5 or so years, we have never had any industrial unrest in MTRH. And Mr. Shet Panyako is here, he can witness. And he knows the secret, what we employed. Can I say the secret? We talk with the unions. We don't fear to talk to the unions because they also mean well. We even remind them about their CBS that it's due for you to renegotiate for your CBS. They don't need to go on strike on that. They don't need to do that. We have also brought them on board. Any decision made in the hospital, we involve all the unions. They are major stakeholders. Yes, and this is what we need to, populate along the way. We talk with them, we have put them in national NHIF committees, in every meeting of the board, they are also represented there, and we have so many, we have worked harmoniously with the unions, and that can also be replicated elsewhere. Your Excellency, as I wind up, I want to say that we need to put more emphasis also on family medicine. You can imagine a doctor, we can say a mother with a baby coming to the hospital. Both of them are unwell. And they see Dr. Duale at his clinic. So, Dr. Duale, being a family medicine doctor, he can even sort out the mother and sort out the baby. This is where we want to go. as we are emphasizing on multi-specialties all along, we should not focus that these communities we come from are resource-strained. If you can walk into a hospital where you can be seen by even one doctor without going to be seen by another subspecialist and another one, that's a lot of money. In conclusion, we want to say this, Your Excellency, as people have talked and given some examples. And there is one example I believe you need to hear. It was very difficult some years to be helped by NHIF if you are a renal patient. If you are a patient with kidney issues, it was very difficult to be sorted out by NHIF. One, they forced you to be admitted to be given dialysis. So they loaded the beds in the hospital. Then you could go in the morning and get dialysis, but they say, we'll treat you as an inpatient. That means sleeping in the hospital. And even after sleeping in the hospital, they say we are not able to clear the entire bill. We'll pay 5,000 shillings, 3,000 on top of that you have to pay yourself. People used to come with consumables, 5 liters of liquid to be used in the machine. And after you have been dialyzed, you go back with your 5-liter container. That's what reminds you are coming from dialysis. Hospital lobbied NHIF for so long. NHIF later on accepted to do dialysis without necessarily forcing you to sleep in the hospital. But they say we are not going to do the kidney transplant. It's very expensive. We said, what we do then? This is a person who we have engaged, we have convinced him to be a member of NHIF. Where can he go elsewhere? Where can he go again to get other money? After we had done several kidney transplants all over, and like before, and the prices went down in public institutions, NHIF now agreed that they are able to do they are going to support the kidney transplant, which was very good. In the private hospital, in the public hospital, kidney transplant is done and NHIF pays. Now, the biggest issue now, Your Excellency, is NHIF does not pay for your medication, which is lifetime. Although your kidney was, found to be compatible with the other one, blah, 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 the body still continuously rejects the kidney as a foreign body. So you need to take drugs every now and then. And you know how much it is, that, Your Excellency? 40,000 shillings every month. So you need to have about 500,000 to have those drugs for 1 year, for example. Now, because you are not able to foot that bill of 40,000 every month of drugs, what happens again? You relapse. You go back again for dialysis because NHIF pays. It will not refuse because it's covered. And the idea of getting kidney transplant was to get out of this dialysis, isn't it? Now, because you are going back again to dialysis, dialysis is a stopgap because you are supposed to go for another kidney transplant, which NHIF is willing to pay for you again. You finish, you replace the other kidney, you are given another one, but you are not paid for the drugs again. So we are finding these people again in the hospital, Your Excellency. It is a very sad story indeed. And that is one aspect of it. Thank you very much.
Thank you very much, Tony. I quite sympathize with especially the last episode you have mentioned. And I think reason should finally prevail the way it has before. I think it's possible to change the mind of people when they get to understand the kind of strain that you're going through. I confirm, because I have been to MTRH myself, that you sometimes find 2-3 people on the same bed and possibly another 2-3 on the floor. and it's not quite it's quite a sight many of us cannot take. But I want to ask about your experience. We tried working with counties to create facilities that are almost at the level of a referral hospital in many more hospitals around the country. Like, for example, we did, I think, 60 hospitals with ICU facility. We did other hospitals with radiology facilities. We did other hospitals with renal unit facilities. Have you experienced any reduction in pressure in MTRH? Because we now have, in the 22 counties you cover, majority of them benefited from the MES, what was called MES, the equipment, mechanical equipment service, or medical equipment services. Did you experience any difference? Do you think that if we scale up facilities in other hospitals, it will ease the pressure you currently are facing?
Thank you very much, Your Excellency. One, you have heard here, Your Excellency, that there are some hospitals with ambulance with no drivers. So it's not very difficult to realize that there are ICUs in counties without manpower. It's a very technical line of technology. So with all those, I have seen in Iten and many other places, even Our Excellency, Ms. Kenyatta's Beyond Zero, they are just lying idle. They say they don't have drivers to drive those vehicles. So we have quite a number of equipment all over, scattered all over. They don't have biomedical engineers to fix even a fuse in it. They don't have doctors to look at them. They don't have nurses. And that's what we are saying here. We have to have deliberate move to train the manpower again, the nursing. Because now even nurses have PhDs. We have nurses who take care of patients in ICU, critical nursing. So counties don't have them, and you had the challenges they were facing initially. And that's why we are saying we have to have a system, although we don't want to say it's a commission, that it takes care, it trains these people, it places them. It can even use the performance enhancing whatever, to monitor them, so that it's easy to deploy them elsewhere. Very few counties, Your Excellency, have managed to train 1 or 2 people, and still they are not confident enough to say whatever they are produced can be used for treatment. So they will still bring it to MTRH again to be read and interpreted. And that, whatever is being brought comes also with the patient. Yes. So the whole range, the whole array of, things to be done, as the Secretary General of Nursing had said, we need to do much, not only getting those items, they are lying idle many places. I remember in Wasingishu, the governor had even to donate them to us because they had no capacity to use them, And that is, it cuts across all counties. So even if we were to bring up this referral hospital I was talking about, sir, like the one of Kakamega, for example, or Garissa, we have to do a deliberate. Yeah? We have to mentor them. This big institution, like us now in MTRH, these counties, we are getting out to help in many ways because it helps us to reduce the number of referral cases to MTRH. So we need now to move again and empower these apex referrals to be able to influence the outcomes around their areas. So we reach out there, we do deworming, malaria, many other things to prevent some of small diseases which end up in MTRH, Your Excellency.
Okay, thank you very much, Mr. Kirwa, for your presentation.
I will now invite Dr. Machogu from Pharmaceutical Society of Kenya.
Okay. Your Excellency, the Deputy President of Kenya, other leaders, colleagues, good evening, good afternoon. Yeah, I'm really happy to be here to speak directly to His Excellency. And Dr. Cohen, please just come hand out the... I've been told to just speak for 3 minutes, so I'll just keep it short and I'll give my presentation to you formally because my members have elected me and sent me with this information. Okay. You have mentioned KEMSA. I have to speak about KEMSA. And I'm not just here because my MP is a gubernatorial candidate for Kisii County on Kenya Kwanza ticket, His Excellency Machogu. I'm also here because I lead the pharmaceutical industry. I've been there for 17 years. I first started working in Marara District Hospital, where I was a district pharmacist. And Dr. Cohen here is one of my members. Someone said we need to send healthcare workers to Parliament. He was running in Isuka West under ANC. Isuka, yes. A handshake happened and he was leading. He won popular vote, but he didn't get the ticket. So, Bwana Deputy Party Leader, tafadhali mpatie nomination at that level. So I will speak on 3 things. The fourth one is NHIF. I'll leave that because today NHIF, 92% of the money they've collected or due to collect this year has already been spent. ICT will help. Yeah, will help curb fraud, and also it will improve efficiencies. I will not talk much into that. I'll talk about leadership, governance, policy, and legislative agenda as my first point. There, you have institutions like Pharmacy and Poisons Board, National Quality Lab. We heard about private hospitals are wondering, why is PPB registering all these medicines and there's no one worried about the quality? So those boards have been running for the last 3 years without a board. They are national entities, but they don't have a board. They've been running without a board. Yeah? So governance-wise, for the last 3 years, going to the 4th. So within the first 100 days, if you can get those boards in place, inaugurated, done deal, Kenyans can be comfortable that the medicine being registered is of quality. KEMSA. Now, KEMSA is the largest pharmacy in this country. The second largest is Meds. Meds deals with the faith-based. Very efficient. No one worries when they buy medicines from Meds. No one worries when they supply Meds whether they'll get quality. Yeah, whether they'll get paid. Yeah? It's a done deal. Yeah? So if we can have governance at KEMSA, already there's reforms happening there. We have no problems with the reforms. But honorable former party, leader of majority in the National Assembly will attest, and we've complained so much to him, he knows he's protected us. Pharmaceutical Society of Kenya has been deleted from the KEMSA Act. Yeah? And once it was deleted, all these things started happening. And now no one is standing on best practice, ethics and professionalism at KEMSA from a governance perspective. Yeah? So if within the first 100 days we can have legislative amendments that return us back to KEMSA, and even the Pharmacy and Poisons Board, we were deleted. Yeah? Again, just, and you know who sponsored those things, rather who brought them to you and the snuck in. Yeah? So we would like to see professionals back to these bodies for governance purposes. A pharmaceutical policy for this nation, there hasn't been any review of the pharmaceutical policy since 2012. Again, within the first 100 days, the directors sitting at Ministry of Health should be able to give you a national pharmaceutical policy that takes you to the vision you want to take the country towards.
Just hold on there,
sure.
Dr.
Yes.
So you're deleted from these boards.
Yes.
What was or the reason is the one we know? You are asking too many questions.
No, you're not asking too many questions. Actually, the reason is the one that is known. When you don't have professional oversight on the boards, decisions get made like buying short expiry medicines that are not required. I used to be a district pharmacist in Samburu. KEMSA, in 2006, 7, 8, I was a district pharmacist in Samburu. KEMSA was the best institution in Africa. Yeah, in terms of supply chain and what have you. But because we are removing professionals from there, there's no oversight. So deals are being cut. Yeah. Asante. I hope I'll get protection. Tunaongea sana. Lakini hii ni nchi yetu na tunaipenda sote. Yeah. Asante sana. Bringing down my second point is around bringing down the cost of medicines. Of course, I have heard you talk about local pharmaceutical manufacturing. What you may not know, Bona Deputy President, is that we import 75% of the medicines coming into this country. That's one. And even those ones imported, costs are laden from taxes. Yeah. So if I need to retain my medicines, the Pharmacy and Poisons Board has to, because it's not funded by the Exchequer. Yeah, one of the things that you need to do maybe in the first 100 days also is review. Should Pharmacy and Poisons Board be funded by the Exchequer so that it stops levying fees that even increase the cost of imported medicine? But even on the part of reversing from 75% to maybe 75% manufactured, if you want to do that, Bona DP, that would be like a 30-year journey. Bangladesh took that long. But yes, if you will take the seat as the father of the nation, what will happen is you need to have that view that you need to work with us as healthcare workers to get you there. How we'll get you there is local manufacturing should be given precedence. Currently, local manufacturers export to Ethiopia. Cosmos is the biggest exporter to Ethiopia, to Malawi. We have 40 pharmaceutical manufacturing plants who are operating at 50% or below capacity. Yeah, you need to ring fence so that we manufacture those things here, at least for the essential medicines, the things that are common. And the next step, of course, is we need to go to, in 30 years, we can get to Bangladesh, who reversed in 30 years by getting to a point where we are able to manufacture cancer medicines, because our 30 years knowledge and skill transfer would have happened. So, I believe we'll pray for good health for you so that you can also be there and see the fruits of that. So you have to plant trees under whose shade you will not sit, but we are looking forward to that. Number 3, pharmacy practice and primary health care. Every patient who goes to a facility leaves, 90% of those patients leave with medicine in their hand. But as they leave, you'll see, because of the facility funds that used to be there, we now have pharmacists, nurses having to mop our places because there are no workers. You know, it used to be called, let me get the exact word so that I don't say my own things. What was it called? Yes, it used to be there. It used to support these things. Now, tunatoa hata pesa yetu ya mfuko kufanya hii kazi. Yeah. Now, these professionals need to be there sitting with the patient, and what I heard someone talk about, value-based, FIS, yes, you are a member of parliament and you know those, I'll get you the exact word, yeah? Because those funds are not there now, yeah, we have to do these things ourselves as healthcare workers. So we like to get, yes, sorry? Oh, we have to, for example, we have to get healthcare workers to do work like mopping the floors, because we can't hire even subordinates, you know, at that level, yeah? Again, for each facility used to sustain itself from the money it makes from its collection. Finally, I think I will not do this justice if I don't mention the point of, when I'm talking about pharmaceuticals, we need to do curriculum review, again in 100 days. We've had curriculum that has been there. When I graduated, there's only one university, University of Nairobi. Now we have even these ones to do train pharmacy, but they have to use the same curriculum. Now we are moving to digital. We need to destigmatize digital so that we can also, as you give us the HMIS to run healthcare, we need to be indoctrinated in the new way so that my notes don't have to be manual, so to speak. And I think that's it from my end. Ile nimesahau nimepeana dossier, and we are available to support this journey. Asante.
One moment. Thank you very much, Mr. Machogu.
Yeah.
I don't mind the 30-year journey, but we have to begin.
We have to begin, yeah.
Even if we did several steps and we are heading in the right direction, that would be the thing to do.
Mm-hmm.
Now, so listening to you, you're saying local manufacture, we should support local manufacture.
Yes.
Is that what you're saying?
Yeah. Yeah.
And you're saying there are already facilities that are working at 50% capacity.
Mm-hmm. Mm-hmm.
And you're saying that we can ring fence the
essential medicine lists
essential
to be
medicine,
manufactured by local
the ones that we know
yeah.
we will certainly need
procure,
them.
exactly.
We'll certainly
yeah.
procure.
The 80% that will always be in need of.
And that's about 80%.
Yes, yes. Of the essential medicines, there are 80% of those medicines, we even have capacity to manufacture them.
Yes.
The issue might be that because we have to import the active ingredients, the cost might be a bit more, but with the incentives that we get to pass that cost back to you as citizens, and also we get to keep the dollars here, yeah, to create more jobs and even build our capacity, because that's how Bangladesh did. Today they manufacture cancer medicines, which we can't today, but 30 years later we can, because we allowed ourselves to build our local industry. Yeah, increase that 50% idle capacity, utilize it fully.
Yes.
Yeah.
So, and yeah, that's what you're saying. You're saying our first port of call is to use the 50% capacity we already have.
Yes.
That is not being utilized.
Yes.
And we can also target immediately essential drugs.
Yes. Yeah.
That's what you're saying.
Low-hanging fruit, essential pharmacy, paracetamol, Flagyl, all these medicines are already, some antibiotics. We have entities that hypertensive medication.
Correct.
Today, Cosmos manufactures hypertensive medication, Rigol. Can we buy that entire consumption of the entire 100% capacity? Yes. That's what I'm saying. Yeah.
Wonderful.
Yeah. It's not being done today.
That's a very good
by that 100%. Tafadhali makofi ya hiyo ikifanyika hiyo, we retain today, we have to look for places to buy dollars because we have to import 75% of these medicines. Why? Just because it's cheaper? Can it also, once we buy that international medicine list, we'll make it cheaper. We'll make it cheaper. Yeah. Leader of majority.
Maybe two questions. One,
yeah.
One of the reasons why they removed you when I asked government was that you are also part of conflict of interest.
Okay. Mm-hmm.
Yeah?
Mm-hmm.
Because big companies who are tendering, putting tenders for KEMSA, you guys had a role, they were your buddies.
Mm-hmm.
So even government was saying, by you sitting in the board, you are influencing.
Mm-hmm.
On the flip side, you're also asking too many questions from the cartels of government.
Mm.
Okay, so both of you, in one way or the other, had crime. So what do you say to that? But secondly, there's also an outcry that it takes very long, even 2-3 years, for certain people to register drugs with the poison board.
Mm-hmm.
That the bureaucracy and the corruption in the poison board is so huge that a lot of international companies give up and they go to our neighboring countries. Is that the case?
Today here, so I'll start with the second question about the Pharmacy and Poisons Board. Like I said, it's just a matter of governance, and I think it's been said earlier by Dr. Oluwen. The matter of, are there KPIs, to ensure that these medicines that are being registered, who is complaining that their medicines are not being registered? And does the president, for example, know? Or as the contract is being renewed for these leaders at the Pharmacy and Poisons Board, are these questions being put into task? And some of the questions we used to bring to you to ask them in the parliament, why is this happening? Why is this taking long? And of course, it's what has gotten us into trouble. As Pharmaceutical Society of Kenya, we are a professional body. Actually, we have a bill in that's meant to come into Parliament that's meant to make us like LSK, just a self-regulation body. We do ethics, we have, so the things you're talking about conflict of interest, that should not come into the case because we go there to ask questions on best practice, public interest, and professionalism. Ethics as well, because you want to be able to, that medicine that you're importing, because even when I'm not there as a pharmacist at the Pharmacy and Poisons Board or KEMSA, I'm the one who will be sitting here outside taking medicine in Maralal. I want to be sure. Today there are suppliers who sell medicine to KEMSA. Ukiwekea dawa yao kwa mwili like this, wanaweza kufa kwa sababu ya the shock. You give me my medicine? Yeah, because they're the ones who are supplying these places, but the quality is not ascertained. And QCL, National Quality Board, has never had a board in place for the last 3 years. Why is that? So that things can come in and go out without anyone questioning. So let's 100 days address that for us. This country will be on a good path. Thank you.
Are we happy? How is the discussion going on? Do you want to stretch like this quickly? Now, we are about to finish, but I know His Excellency, there's so much interest in the room. So I would humbly request you, we have 3 or 4 more other speakers. Now I want to be a dictator. You'll be given 1 minute each so that we allow everyone to talk. Is that okay with everyone? Okay, so that His Excellency the Deputy President can address us. So at this point, I want to call Juliet Otieno. Juliet is the representative of the Coalition of Community Health Workers. Madam Juliet, you have a minute. Thank you.
Good afternoon, Your Excellency. All guests, all present here, thank you very much.